Okay, so we're going to start now with the different medical emergencies. So tonight, probably tonight and a little bit of tomorrow night, we'll do respiratory because it's a long chapter, and cardiac. And then the following night, we'll do pharmacology. So probably next 2 or 3 classes will be respiratory, cardiology, and then pharmacology. And then we'll pick up with the rest of the medical emergencies. Okay, so just bear with me, I'm using a different computer. Okay, so just a quick review of the anatomy and physiology, right? So we know that we said that breathing has both a mechanical part, right, which is muscles moving, and that the 2 main muscles of breathing were the diaphragm and the intercostal muscles between the ribs and over the rib cage. And that to breathe, there has to be a couple things going on. First of all, there has to be the stimulus, right? Something wanting to make the body breathe. And that's the brain monitoring the level of carbon dioxide in a healthy person. When we do respiratory emergencies in a few minutes, we'll see there's a disease called chronic obstructive pulmonary disease, or COPD, where because the levels of carbon dioxide are always high in the body then looks at the level of oxygen. So right now in a healthy person, it's going to look at the levels of carbon dioxide. And if carbon dioxide is high, it's going to make you breathe more. But in that other situation where, they have that respiratory disease, it's going to look at the level of oxygen. And it's going to go the opposite way, that if the level of oxygen is low, it's going to make the person breathe more. Okay, so the brain's doing that. When it sees that the person needs to breathe, it sends a signal to these muscles, okay? And the diaphragm, which is the muscle that separates your thoracic cavity, your chest cavity from your abdominal cavity, it makes it contract. And when it contracts, it goes downward, okay? And it makes your intercostals tighten and pull your chest out. So the combination of your diaphragm going down and your intercostals going out increase the size of your chest cavity. And as your rib cage is pulling out, it's pulling your lungs with it. It's stretching your lungs. So all of that basically makes the pressure in your lungs go down. It goes down less than the pressure in the room. And once the pressure inside your lungs is less than the pressure in your room, air flows in, right? So that's basically how breathing occurs in a healthy, normal person. Okay, so we said that inhalation or inspiration, however you want to say it, is the active process because the muscles are actually doing something. Okay, so again, on the test, there's definitely going to be a question which says which is either the active phase of breathing or the passive phase of breathing. So active means that something's happening. Remember, breathing in means the muscles have to move, so something's happening. Okay, so inhalation is the active phase when air is being pulled in, again, because the muscles are contracting and increasing the size of the chest cavity. Exhalation or expiration is the passive stage because the muscles are just relaxing. The chest cavity, the thoracic cavity gets smaller, okay? And once it gets smaller, the pressure has to increase, right? Because everything's coming in onto the lungs. And once the pressure gets higher than the pressure in the room, in the atmospheric air, you exhale. So that's all it really is. And it works well, again, until we have some problems with either airflow, like with an obstruction, or with damage to the integrity, the solidness of the chest, like when we saw pneumothoraxes and stuff like that. So we'll go over all those things tonight. Okay, so now tidal volume, we said before, was the amount of air that somebody breathes in and out with one breath, right? And that's about 500 mLs in a male and about 400 mLs in a female. So at every breath, you're moving that. And we always use the analogy of a bottle of water is about the amount of air that we breathe in and out with each breath. And obviously that's capable of changing, right? I mean, we can greatly increase that if we're exercising or something like that. And there can be situations, mainly because of drug overdoses, where we start to breathe real shallow and decrease the amount of air. Okay, so again, tidal volume, the amount of air that you come in and out, 500 for a guy, about 400 for a lady. And all minute volume is that you times that tidal volume, right? So say that 500 by how many times somebody's breathing in a minute. So all minute volume is what's the total amount of air in a minute, not the amount of air in one breath, but the total amount that you're moving. So it's the amount of the tidal volume times how many times you breathe a minute. So again, if it's 500 times 10, it would be 5,000 mLs, right? So that's, how much everybody breathes in 1 minute. Okay, so when somebody has adequate breathing, right, one, they have to have a good airway, right? Remember, that was a patent, P-A-T-E-N-T, patent airway. They have to have that means the airway has to be open. There's nothing obstructing the air coming in and out. They have to have the brain working well to send signals that the person wants to breathe. So how do we tell that? So just visually, we look at someone that doesn't look like they're struggling to breathe. We've all seen people, whether they were exercising or working hard or something, where it looked like they were having trouble breathing. They always use the term speaking in a full sentence, which means that somebody who's acutely short of breath, right, really having trouble breathing, tends to speak in 1 or 2 word sentences. They can't, formulate an entire sentence because they have to take a breath before they get all those words out. Okay, again, no cyanosis, so you see no blue grayish discolorization around the lips. Their mental status is clear. Now, when somebody first starts to have trouble breathing, it's not like they're going to become unconscious. Actually, what happens when they first start having trouble breathing is they get very nervous and anxious, they call it. In other words, they sense something is not right. Nothing scares us more than, not being able to get air in. So they become very anxious, scared. They're actually not very cooperative with us, and when we try to help them, this is one of the reasons why when we strap an oxygen mask on someone, they pull it off because they're so nervous and scared. They feel something's in front of their face, and when they go to take a deep breath, they feel like they can't get that full breath in, even though the air they're breathing in when we give them oxygen has 100% oxygen versus the room air that only has 21% oxygen. They don't sense that difference in oxygen. They just sense that you put something in front of their face that makes them feel a little, claustrophobic and restrictive in their breathing. So they tend to rip it off. Okay. And when they say orientation, so when you talk about mental status, you have to say that somebody is alert and oriented. So alert means they're looking at you, they're awake, they're conscious. Oriented means they know what's going on, right? They know who they are, where they are, okay, and what's going on. So we say person, place, and event. Some people put the day of the week in there. I don't usually ask people a date again because it's, most people, I mean, it's the first of the month, so I guess we know it today, but a lot of people wouldn't necessarily know what the date is. But it's not enough to say that someone's awake, right? You have to say how oriented they are. In other words, how much do they know about what's going on and stuff like that. Okay, as far as breathing rates go, again, these are just general numbers in a patient who is not in distress. So this is, what you're basically going to kind of questions you're going to see on a test. So 12 to 20 breaths for an adult, 15 to 30 breaths for a child, 25 to 50 breaths for an infant. Again, very wide ranges, but as people get older, they tend to breathe slower. Okay, up to a certain point, right? When you typically get over the age of, say, 65, 70, your respiratory rate starts to increase a little bit. But not anywhere near the respiratory rates of children and infants and stuff like that. Okay. The rhythm, which means the time between each breath, is the same, right? So they're not breathing irregularly. Okay. And breath sounds, again, when you listen with a stethoscope, not that we really go into that in great detail in EMT class, but their breath sounds are they have them bilaterally. Like if they didn't have them, remember, bilaterally means both sides of the chest, right? Lateral is side, bilateral is both sides. That they do have them. That's more something we listen in trauma or in a pneumothorax. Okay, that they're breathing equally the same amount of air and that there's no abnormal sound. So we'll talk a little bit about sounds tonight. On YouTube and stuff like that, there's tons of videos of different breath sounds. But again, the only way really to get good with breath sounds is to listen with your stethoscope on people. So like I was saying, you should try to take vital signs, listen to lung sounds, and as many different types of people, ages of people, male, female, everything like that. And that's really the only way you kind of get an idea of what you're starting to listen to. Okay. Now, when we say inadequate breathing, it's that somebody seems like they're having trouble breathing by our visual, observations. Their respiratory rate may be too high or too low with no explanation, right? I mean, if they're exercising, it would be acceptable. The rhythm may not be regular. They may have diminished lung sounds, and if they have diminished lung sounds, they should also have poor tidal volume, right? Because if they're not breathing enough air in, it should be that their tidal volume is dropped. Now, if you think you hear very diminished breath sounds, one of the things you always want to check is that you're listening actually over the lung, right? Sometimes we not paying attention where we put our stethoscope, or we're listening over clothing, okay? Or maybe you have the head of the stethoscope turned the wrong way, right? Some stethoscopes have two sides, and if you're not hearing anything, it could just be something as simple as your kid was playing with your stethoscope and turned it the wrong way. And, you don't know. Usually the first thing you do when you put your stethoscope in your ear is that you just gently with your finger tap it, okay, so that you know that it's actually on the right side, okay? Now, pediatric size, again, we talked about that the airways are smaller, right, just because a child is smaller, so they're easier to be obstructed. Again, proportionally, which doesn't mean the kid's tongue is larger than an adult's tongue, but just proportionally, a kid's tongue tends to take up more space in a kid's mouth than an adult tongue does in an adult mouth. And since a tongue is really just a muscle, right? And if it relaxes because the person's unconscious, it would, on a pediatric wise, it's easier for the tongue to obstruct the airway. Okay, the trachea is not rigid yet, the way an adult trachea is. Again, a trachea is not really bone, it's cartilage, so it's never going to be as hard as a bone, but it's in a child, it's more flexible. So depending on the position the child's head is in, it could actually kink off the trachea and close the airway. Okay, and again, the cricoid cartilage is just a portion of the cartilage of the trachea, so that's not really a big deal for us. And that the other thing would be that kids are primarily breathing with their diaphragm. We use our diaphragm in our intercostals. In kids, they primarily just breathe with their diaphragm up until probably around the age of 6 or 7. So that if you're only using one set of muscles to breathe, it's obviously easier to tire those muscles if the kid's having a problem, if they have a pneumonia or some type of problem, so that they could actually just kind of wear out those muscles or tire down those muscles easier than an adult can. Okay, in kids, we talk about nasal flaring, that when they're breathing real hard, sometimes you'll see this area of the nose kind of flare out. Grunting is a type of sound that kids, when they're having a lot of trouble, make. Seesaw breathing means that when you see the chest go up, right, when they're breathing in, you see the chest expand, you see the stomach going in, and vice versa. So there you see the stomach and the chest going this way, like the seesaw that you see your kids playing on in the park. Okay. And retractions means that the space between the ribs, okay, is getting tugged in with breaths. Now, in some kids, if they're really, really thin, you can see between their ribs. We're talking about that it's actually tugging in. Okay. Now, so if somebody's not having trouble somebody is having trouble breathing, what do we need to do for them? So if they're not breathing deep enough and well enough, in other words, enough times a minute with adequate tidal volume, then we have to force the air into them. So we have some different devices. Nobody really uses the pocket face mask in EMS. I'll just tell you that. That's the mask that you may have gotten, with CPR and practice with at CPR, but nobody really uses that, on an ambulance in EMS. If that's all you had and you're in your car, I mean, that's fine to use it, but nobody really uses that EMS wise. Okay. What we do use is the bag valve mask. Okay. So the two rescuer way of using it, where one person is making a 360-degree seal around the mask and holding the patient's airway open, is the best way, and the other person squeezing the bag valve mask. If not, then you have to do it by yourself, which is, one rescuer. We don't use this device. I don't know if you remember it from when we did the airway section, but this was that device I said that was hooked up directly to the tank with a lot of pressure, and that you pressed a button on it and it forced air into the patient. So we don't really use that. And then the other way would be just using one rescuer bag valve mask. Most of the times, unless you get there totally by yourself, you're always going to have more than one person. So you would do two rescuer bag valve mask. Okay, so when we're ventilating, we should see the chest rise and fall, okay, with each breath. And again, inhalation, exhalation should be pretty much equal, okay? And in adults, we give one breath every 5 to 6 seconds, so about 10 to 12 breaths per minute, okay? And children and infants, one breath every 3 to 5 seconds. So now, what happens when somebody, somebody senses they can't breathe, or somebody's oxygen level tries to fall? So we said they get anxious. Because they get anxious, they secrete adrenaline into their bloodstream. Because they secrete adrenaline into their bloodstream, their heart rate increases. So you're typically, when people are having trouble breathing, you are going to see an increase in their pulse rate. But if you get a situation where somebody was having trouble breathing for a long period of time, and you get there and their heart rate is very slow, that means their oxygen level has fallen so low that the heart doesn't have enough fuel, right? Doesn't have enough part of the oxygen fuel to actually beat. So that's a very scary sign, okay? And again, in kids, their heart rate is very fast, right? So a heart rate really going below 100 in a small child, or say below 80 in a middle-aged child, would be, again, significant. And people, adults, we're talking about probably heart rates going below 60, 50, 60 would be signs that the heart is not getting enough oxygen on its own to, to beat. And we would have to increase that amount of oxygen by ventilating them with the, the bag valve mask if they're not breathing well on their own. If they are breathing well on their own, then it would probably be a non-rebreather or nasocannula to increase the amount of supplemental oxygen. Now, to give us a rough idea of the level of oxygen in their capillaries in their bloodstream, okay, how saturated the hemoglobin is. In other words, how much oxygen's on the hemoglobin molecule. We have a device called the pulse oximeter, okay? Pulse oximeters do have some limitations, right? So if somebody says to you, I feel like I can't breathe, and they're having a totally normal pulse oximetry, you should probably assume the machine is wrong and not that the patient is, exaggerating or something like that. So a rough idea of a normal pulse ox is somewhere between 94 to 100%, okay? Under 94%, we consider it to be starting to get low. So between 91 and 94%, it's, mild. Once it gets below, say, 91%, we consider it to start getting serious. It's very rare that you're going to see people have pulse oxes below 94%, okay? The other night, Sunday night, I went on a call where it was a house with 3 people, 3 adults that all had COVID, okay? And the husband and the daughter were in a week into it. The mother just got it. So they really called just for the mother because she wasn't feeling so well. So we wound up checking out all of them. Okay. And all their pulse oxes were back up above 94%, except the mother that was satting at about 92%. But what's interesting is she had no complaint of feeling like she was short of breath. Her complaint was she just didn't feel right, which is a lot of times what you early on in COVID people say, like they just, don't feel good and everything like that. But, the rest of them who were about a week into their COVID, all their pulse oxes are above 94% on room air, right? They weren't on oxygen, just on room air. They had various different complaints of headaches and, achiness and stuff like that, but not, not the hypoxia, the severe hypoxia that we saw in the springtime, late winter, springtime with patients, right? Then we're going to patients and their pulse oxes were in the 80s. It was very common to see people with their pulse oxes in the 80s, and stuff like that. So it's the virus definitely has mutated or changed a little bit. I mean, there are still some people having a lot of respiratory problems, but not as common as it was in the springtime. Okay, so again, pulse oximetry. Basically, I think that you probably see people using pulse ox pretty much on every patient. It's kind of considered like another vital sign, just like you take pulse and respirations and blood pressure and stuff like that. So years ago, we usually just put it on respiratory patients, but there's no harm in putting it. It takes 2 seconds. There's no harm in putting the pulse ox in a patient. The only thing I would caution you on is that you are going to get a heart rate on the pulse oximetry besides the level of oxygenation. You should still manually feel for a pulse, okay, on a patient. Just because it's telling you, remember, pulse rate is different than heart rate. So pulse rate is the pulsations that you feel, okay, of the heart going through. The heart rate is not going to tell you on the pulse ox, is not going to tell you how strong the pulse is, how regular it is, right? It's just going to give you a number. So the only way to really get a good assessment of somebody's pulse rate is to put your hand on a pulse site, typically the radial pulse in the wrist, okay, in a conscious patient, and count it yourself and feel the strength of it and the regularity of it and everything like that. So you shouldn't get into bad habits right away. You'll see people, all they do is, put the person on the pulse ox and they never actually touch the patient and stuff like that. So, you should be taking a pulse, okay? Now, what are the limitations of pulse oximetry? So it is not a good device if where you're putting the pulse, where you're putting the probe doesn't have good blood flow, right? So right off the bat, if the person's cold, okay, if they have nail polish on, if they're in a state of poor perfusion, hypoperfusion, like in shock, obviously if they're in cardiac arrest, there's going to be very poor blood flow or no blood flow. So in all those situations, the pulse oximetry is not reliable, okay? And it would be a useless, situation to put it on. I mean, you're not going to harm the patient, but the number is going to be totally inaccurate. Now, in carbon monoxide poisoning, it's a different thing, right? In carbon monoxide poisoning, the issue is that, and we'll talk about that, coming up, is that the carbon monoxide molecule, the hemoglobin likes the carbon monoxide molecule more than it likes the oxygen. So what happens is that the carbon monoxide coats the hemoglobin where the oxygen should be going on. It doesn't let the oxygen go onto it. So therefore, the oxygen can't get into the cell because we know that hemoglobin is kind of like the wheelbarrow that carries the oxygen into the cell. So if there's not hemoglobin, we can't get the oxygen into the cells. So what happens is that the pulse ox is looking at the level of oxygen in the bloodstream, not in the level of oxygen in the cell. And since none of that oxygen can leave the bloodstream and get into the cell, the pulse oximetry is going to give you a very high reading in carbon monoxide poisoning, but it's not telling you what's going on a cellular level because all those cells are starving for oxygen. So it's a useless device in a suspected carbon monoxide poisoning. Again, we do have a different device. Every ambulance in Rockland County was issued one per ambulance of a carbon monoxide called the RAD 57, but it looks like a pulse ox. It does pulse ox, carbon monoxide, and heart rate and monitoring on it. So
going to give you a high reading in carbon monoxide or a reading in oxygen?
It gives you a high reading. So if you were to put a pulse ox, we're talking pulse ox, not
Right.
57. So if you put a pulse ox on somebody with carbon monoxide poisoning, it gives you an abnormally high reading of oxygen because the level of the oxygen in the bloodstream is high. Okay. But the problem is that we do care about level of oxygen in the bloodstream, but in this case, we're more concerned about the level of oxygen in the cells, right? Because the cells need oxygen to make energy. So since it can't get oxygen, can't get on the carbon, I'm sorry, the oxygen can't get out on the hemoglobin, the cells are starving for oxygen. So if you were to put the pulse ox on them and it's looking at the blood, it's going to say it's 100% perfect, but that's not really telling you the true story of what's going on inside the body. Okay. Okay, so when we say somebody's having trouble breathing, sometimes we describe it as shortness of breath, right? Trouble breathing, difficulty breathing, whatever it is that it is. Now, obviously, it's the patient's perception, right? It's their subjective perception. I feel like I cannot catch my breath. They have, it's a mental sensation that the brain tells them when the brain senses the level of oxygen is dropping and the level of carbon dioxide is increasing, right? So they feel that trouble. We've all had it when we had a chest cold, right? When we felt like it was hard to get a breath in, or, maybe we were exercising, or maybe we were breathing in some dust or something, and, our throat tightened a little bit and stuff like that. Now, again, some patients tend to exaggerate. So, they could say to you, I feel like I can't get a single drop of air in. Okay. And they're not that bad. And then other patients could be pretty bad, but they're not complainers. So it's sometimes hard to gauge, how much trouble somebody is having in breathing just by what the patient tells you. So that's where we have to, again, use our different tools, our pulse oximetry, our visual observation, our stethoscope, and stuff like that to get an idea of what's going on in the patient. Now, when you get there and you see somebody, this is what's called tripoding perception. I'm sorry, perception is how the patient.
Frank, can I ask you something?
Yes.
If the patient complains, I cannot breathe, the minute he's talking to you, his airway is open.
Right. But again, it depends on how he's talking to you, right? So if he's talking to you in one word sentences, I takes a breath again, can't breathe. Okay. That's probably a more legitimate than somebody who's talking as fast as I am. If I'm talking this fast and telling you I feel like I can't catch my breath, then you kind of know that it's more psychological. There's not really probably a respiratory problem going on in the patient. So perception is how you perceive something, how you sense it in your body, I guess is the best way to describe it. So, how you sense that you feel like you cannot breathe would be, I guess, a good description of perception. You feel like you're having trouble breathing. Now, when somebody, is having trouble breathing, they tend not to lay flat. That's the first thing I'll tell you, right? They don't like to lay flat. It's much harder for somebody to breathe if they're laying flat. Okay. Now, what they do like to do is sit up. A lot of times they like to lean forward and they like to go what's called in a tripoding position. So tripoding means is they're using their hands. A tripod, like on a camera, has 3 legs to it. So you got your 2 arms and your butt, right? So tripoding is, there's 3 things kind of supporting the person's upper body. And what they do is they're actually pressing down and they're lifting their chest part of their body up a little higher. And that allows their diaphragm to come down a little lower. Okay. And that allows them obviously to get a little more air in. So again, it's not something they learned. It's not something their doctor told them. It's just that adapting to having trouble breathing, right? That they find a comfortable position, just like anytime we're uncomfortable or in pain, we try to find a comfortable position. And this is a position they typically find in. Sometimes instead of their hands being on their knees, they'll actually rest their hands, like if they were sitting on a firm chair or something like that, or the chair with arms, they'll actually be pressing down on the arms of the chair, kind of like this to, prop themselves up. So they'll be leaning forward with their arms pressed down on the arms of the chair, leaning forward. So
Is that a beginning sign?
That's a pretty, definitive sign of somebody having trouble breathing. Okay, I'm sorry.
Is that a beginning sign or a late sign?
So I would say it's probably, again, it depends on the person, but it's definitely somebody who feels like they're having trouble breathing. So whether it's going to be early or late depends on how much tolerance the person has for it. I've even had people who are having trouble breathing, right, that sometimes would actually try to walk around, and all the walking around would do is make their trouble breathing worse. So, it really just depends on what the patient finds is feeling comfortable. Sometimes you'll find them standing up, right? So they're standing up and they're leaning over the counter. So they're kind of like this. And again, that's just trying. When you're sitting or you're lying, it's much harder to breathe. So sometimes they'll actually stand up and press down to, So close the door. Okay. I'm sorry, I'm talking too loud and my son's taking a test. So, they're having such trouble breathing that they sometimes even stand up and press down like that to be able to get a little more air in. Okay, now you remember from when we were talking about assessment, we had the OPQRST, onset, provocation, quality, radiation, severity, and time. Those are just a mnemonic to help you remember the questions to ask when somebody calls you with a complaint. Right. So somebody calls you to the house and they say, I'm having trouble breathing. So onset would say, when did it happen? Okay. Provocation is, what were you doing when it came on? So it could be they tell you it happened 30 minutes ago while I was sitting here. Right. So, you'll see when we talk about some other breathing problems, a lot of times it could happen with a cough. It could happen with exertion. Exertion means they were doing something, or it could just happen. There's even people say I woke up from, I was awoken from sleep with a sensation I couldn't catch my breath. And we'll talk about all those different, what those different descriptions of symptoms are, depending on, the emergency and stuff like that. So quality, again, if it's pain, we ask them on a scale of 1 to 10, with 10 being the worst to describe it. Breathing difficulty, we could ask them, have you ever had this problem before? Can you tell me how this episode is as compared to previous? Okay. Or you can get into specifics. Do you have a productive cough? A productive cough means they're actually bringing up some mucus versus a dry cough that's not. So, quality is basically asking the patient to, add some description to their complaint. Okay. Radiation. Okay. When it's pain, we ask them, does the pain go from, let's say they're saying they're having chest pain or lung pain. Okay, point to where the pain is. Okay, is it going anywhere else? Do you have any other pain in your body or anything like that? Is it moving to any parts of your body? Severity, again, on a scale of 1 to 10. Okay, how bad, you say on a scale of 1 to 10, with 10 being the worst, how bad is your breathing right now? How bad was it started? And then obviously, if you're treating them, let's say you're giving them some albuterol or you're giving them oxygen, you ask them, okay, what's the, is the oxygen improving things? If they said to you, my breathing was a 9 out of 10, now I put you on oxygen, how is it? Okay, I gave you an albuterol treatment, how is it? And so on. So you just ask them to it gives you a numeric idea of how your treatment is going and stuff like that. And again, time. Okay, so how long has it been going on? And we kind of figured that out also by the onset, right? In other words, because they told us when it started, we can get an idea of time. Somebody asked me the difference between a productive cough and a non-productive cough. So productive cough, again, okay, means that somebody is bringing up mucus. They're producing something, right? Versus a non-productive cough. So sometimes like people could have let's put it this way, typically viral and bacterial infections in the lungs produce a lot of mucus, right? You always have mucus, but the body produces excess mucus. And sometimes the mucus is actually colored, right? You'll see green mucus, or, depending on the situation, sometimes you can even see blood in the mucus when they're bringing it up. So does it really change things a lot? No, but typically people who have a cough without mucus are not as sick as people who have a cough that's bringing up a lot of mucus. The other issue we'll see is in certain diseases, if there is a lot of mucus, that could actually cause a plugging of the bronchioles if it dries up. That's why the other day, I think whenever last time we were talking about respiratory, I talked about the importance of using humidified oxygen, which is adding moisture to the oxygen by running the oxygen through a humidifier before it goes to the patient. If you're giving somebody just dry oxygen, right, oxygen with no humidity in it, the oxygen in an oxygen tank has no humidity in it. You could take that mucus, right, and dry it out, and it will become like a plug in the person's airway. So we'll see that in a couple of minutes when we get to some of the respiratory emergencies. So the difference between onset, okay, and time. So usually, onset is more or less kind of, when I do onset, I kind of do onset and provocation. I'll say, when did it start? Okay. And, what were you doing and when it started? So time, again, is, like I said, it's kind of just it's kind of a calculation you probably do in your head more than asking the patient, but if you're at that point, again, just, you could say, just to make sure I'm clear on it, you're saying you're having trouble breathing now about 30 minutes, right? So then you just make sure that one of the things you're going to find with patients actually is that their story changes a lot from, so you're going to ask questions. Then the paramedics are going to arrive. They're going to ask questions. You may have told them, the paramedics arrive, and you may say, oh, the patient said, they were sitting in the chair having trouble breathing. It started about 15 minutes before they called for us. And then paramedics get there and say, okay, so you were sitting in a chair and you're having trouble breathing for about 20 minutes now. And they'll say, no, actually, I was walking up the stairs and, 4 hours ago, and that was the first time I had trouble breathing. So, and you're going to look at the patient saying, well, you didn't tell me that. That's just what happens. And then when we get to the hospital, a lot of times the story is different again. So it's just the nature of, the way things go on, especially if you've made the patient start feeling better by the time you got to the hospital, you'll see the story changes a lot because, one, they're feeling better, so they're concentrating more on their problems. Okay. And, if you made them feel better, they may not be describing to the doctor quite how short of breath they were when you got there, because they don't think it's such a big deal now because you made them feel better. So you shouldn't feel bad about it. I mean, it happens all the time, where, you will hear one thing, or I'm sorry, the patient will tell you one thing, they'll tell somebody else another thing, and they'll tell somebody else another thing. And, you basically have to say to them, okay, we got 3 versions of the story now. Which one is the one we're going to stick with? Because, we can't have 3 different versions of the story. So which is the right one? Okay. So when we look at a patient, okay, so we're looking, are they anxious, right? Are they nervous? Okay. Do they have an altered mental status, right? And people who have long-term breathing problems, like this man did, right? So he's dead now, but I guess they took a picture of him before they buried him. Okay, when people have long-term breathing problems and they have to use their respiratory muscles so hard every minute of their lives to breathe, okay, they get what's called a barrel chest. They're very thin, okay, and you could see their ribs, and they get this very defined, okay, almost muscular chest. And this is just, again, not that they were exercising, because they could not exercise anymore because they could barely breathe. But since every breath took such effort, okay, they obviously developed a very exaggerated, muscles in their chest, and their actual rib cage shape starts to change. This is very common in people who smoked all their lives and developed emphysema. Is what they call barrel chest in emphysemic patients. So, that's one of the, again, it's not a good sign. It's not like they were exercising. They are not at the point in their lives anymore that they could exercise. Again, the tripoding position, so they like to sit with their legs, always with their legs dangling, especially if they're having problems with too much fluid, because by dangling their legs, they pull some of that extra fluid down towards their ankles. And again, they like to lean forward, whether it be sitting or standing, lean forward. It helps them get a little more air in. Okay.
What is emphysema?
I'm sorry?
What is emphysema?
We're going to talk about it in, what time is it? I don't know, probably about a half hour or so, I assume. So that's one of the things that we're going to be talking about tonight. I think we start with asthma and then we go to emphysema, but it's, we'll be talking about that in a few minutes. So what else do you see? So again, retractions is the in-tugging between the ribs. Okay. Accessory muscles are any muscle that you see being used to breathe, with the exception of your diaphragm and intercostals, because your diaphragm and intercostals are the normal muscles of breathing. Accessory means in addition to. right? So an accessory muscle in somebody having trouble breathing would be like you see their shoulders and their neck, all these different muscles moving when they're trying to breathe. Again, flared nostrils. Pursed lip breathing, again, is very common in the emphysemic patient where they breathe and they go with their lips pursed up tight like that. They don't know to do that. They just know that it helps them to breathe when they do that. And why they're doing it is that they actually don't exhale as completely as if they would if their lips were wide open. And when you don't exhale completely, you keep some pressure in your alveoli and you keep them opened. And the disease of emphysema, again, that we're going to talk about, is the disease where the alveoli, instead of staying open like a sac, collapse. And if every time a person breathes who has emphysema now, they have to force air to open up their alveoli, where in us right now, it's always open. So it's harder for them to get air down to their alveoli. So they obviously have less gas exchange in their alveoli. So by breathing with those pursed lips, they actually help to keep their alveoli expanded. It's just a compensatory mechanism.
Is that the crackling sounds that you hear when you listen in auscultation?
Nope. That's, again, lips. We're not talking about lungs, the lips up here. So we'll talk
No, I'm
about.
talking about when you said the alveoli collapse and then they open up again.
So you typically can't hear the alveoli really re-expanding, but a crackling sound in when you're listening to lung sounds typically means there's some fluid in the alveoli. Remember, the only thing that should be in the alveoli is air. So we're going to talk about all those different lung sounds and the reasons why it's there and in what types of emergencies you see it. Okay, again, patients that can't speak in full sentences would be another sign of difficulty breathing. Late signs, again, where the skin starts to get cyanotic, okay? Pale skin typically is somebody who's cold or somebody who's shocky. So that's not a common thing in respiratory unless it's really towards the end stage. Flushed skin is somebody who's warm. So it could be in somebody having trouble breathing if the trouble breathing is caused by a virus or a bacteria and a person gets a fever with it, right? So you could see somebody with flushed skin, red, flushed, moist skin, right? Pedal edema is where the ankles swell when there's too much extra fluid in the body. Typically, it's because the heart is weakened and can't pump effectively. So we'll talk about that when we talk about cardiac emergencies. Sacral edema, so you know that the spinal column is divided into sections, right? So it's cervical, okay, thoracic, lumbar is lower back, and then you had sacral and coccyx, which are your real lower backs, like down by your butt. So again, the parts of the body that are lowest, closest to the ground, or where the fluid is always going to pool, right? Because the fluid pools downward, flows downward. So if you have too much fluid in your body, you're going to see in the ankles, and very rarely you're going to see it in the lower back. That's typically people who are laying in bed, like in a nursing home. They don't get it down in their ankles because their ankles are not, the lowest part facing the ground. Their back is, so they get it over their sacrum. Okay. And again, we look at oxygen saturation as long as that we trust the reading to the pulse ox probe. So in other words, person's not cold or anything like that. And we'd like to see it above 94%. So again, here's a person, doesn't look too old, but was probably smoking since he was like 12, right? And he's got that, very defined chest, no extra meat on him, sitting, okay, leaning forward, hands on the knees. So he's tripoding. And you could almost see how he's using all these muscles in his neck and everything. And he's kind of looks like he's concentrating on every breath, right? So this would be somebody. Now, this could be a guy having an asthma attack. We don't know, right? This could be a guy who has that emphysema. We have to do more of an assessment and find out what's going on with him. And, obviously the patient will know what conditions he has. It's pretty rare that we go to somebody who's having a breathing problem and they haven't had it already, right? In other words, they know what their breathing problems are. Okay, so, when we talk about different problems with breathing, we have upper airway sounds and we have lower airway sounds. So lower airway would be the lungs, upper airway would be the throat, okay? So this would be a lower airway because this is in the lungs, so wheezing. So audible wheezing means that you hear it when you walk into a room without your stethoscope even on. So you can get people that are having such tight lungs that they have this whistling or wheezing sound that you hear even without a stethoscope. And, some of you have heard that in your children, right? That they're, in wintertime, they get a cold and you actually hear the sound, or some of you may have kids who have asthma or bronchiolitis or RSV, and you could actually hear it without a stethoscope. That's usually more common in kids because they have a very small chest. They don't have a lot of meat on them, so it's easier to hear it without the stethoscope. Gurgling, now gurgling here, they're talking about in the upper airway, so in the throat, right? And that's typically that somebody vomited or has too many secretions. They need suctioning of their upper airway. Could be blood if it was trauma. Snoring, again, we talked about the tongue relaxing and causing a partial obstruction of the upper airway, right? So that's the snoring sound you hear. If the tongue completely obstructed their airway, you wouldn't hear snoring, you would hear nothing. And that's how people die from sleep apnea. Crowing and stridor are kind of the same thing. That's where the larynx, the top of the trachea, spasms closed. It could be from a infection. It could be from breathing in something like dust or a little insect. It could be from an allergic reaction. There's a lot of different reasons, but that's an inspiratory sound. Again, an upper airway inspiratory sound where you hear somebody going, taking a very long time, and it's making a very distinctive sound coming in because the larynx, the top of the trachea, is tight. Okay, now, unfortunately, on a BLS level, we don't have any real good drug to treat that. So that's kind of a drive fast to the hospital. And that's usually a real, serious emergency. Somebody's having stridor. Now, if it's stridor from an allergic reaction, you do have the EpiPen, and the EpiPen will deal with all the problems of anaphylaxis, of a severe allergic reaction. So we'll talk about that in a couple of nights when we talk about allergic reactions. Coughing, obviously, is the sound of there being something in the lungs that the body wants you to get rid of. So that's more of a lower airway sound. So again, a lower airway would be the wheezing and the coughing. Upper airway would be all of these, the gurgling, the snoring, the crowing, and the stridor, because that's all dealing with above the lungs, right? So it's the upper airway. Okay, so I put some lung sounds here, right? So wheezing is the lower airway. It's the bronchioles, so the smaller airways. It typically happens on exhalation, and we see it in asthma and anaphylaxis, and very rarely in congestive heart failure. I know you don't know what all these terms mean yet, okay, but we're going to go over them, and you're going to see when we talk about them, we'll talk about wheezing being one of the sounds. So long and short is that wheezing is a spasming or tightening of the bronchioles. So if you have a tube and they're getting tighter, air becomes harder to get through, okay? Now, the reason that you hear it at first on the way out is that on the way in, remember we said that's the active phase, that air is coming in under force. So what it actually does is it takes that narrowed airway and it opens it a little bit so you don't hear the wheezing. But exhalation, air leaving the body, we said is passive. There's not a lot of force. So as the air tries to work its way through this narrow tube, it's much harder and it makes a whistling sound, just like if you were to put your fingers in your mouth and blow and whistle. It's kind of the same thing, not as loud, obviously, but it's kind of the same thing. So wheezing typically starts on when somebody's exhaling or expiring. And as they get tighter, you could have it both ways. That's called biphasic wheezing. So when they exhale and inhale. And then obviously, if somebody's having a real severe asthma attack or really bad allergic reaction, they could actually tighten their airways so bad that they get no airway through, and then they would actually have a silent chest. But you know that that's really pre-death, right? I mean, if they're not moving any air, they're going to die. Rails or crackles is a lower airway sound. It's when excess fluid builds up in the alveoli, okay? It's typically heard on inspiration because as the air goes into the alveoli, it's popping in the water. It's making the water molecules pop. That's the popping sound. They say it sounds like if you would take hair, you bring your finger next to your ear and crackle your hair together, that's kind of the sound it sounds like. You really need to listen to it, to be honest with you, on somebody to hear it. Okay, and again, there's good tapes of it, but nothing beats having your stethoscope on and listening to it. Now, we see that in congestive heart failure, that's CHF, and acute pulmonary edema is the same thing as congestive heart failure, but it's more the emergency stage. When we talk about congestive heart failure and acute pulmonary edema, you're going to find out that people can be in congestive heart failure every day of their lives, and they're managed with medications to help them get rid of extra fluid and stuff like that. When they have the emergency where they say they can't breathe, that's called acute pulmonary edema, because acute means sudden. Pulmonary means lungs, edema means fluid, right? So they have an acute filling up of their lungs with fluid. Rhonchi is the sound that we've all kind of had, which is when you get a chest cold, when you have excess mucus and you get a chest cold, right? So that's, again, in the lower airways, the bronchioles are filled up, okay? That's why it's called a bronchitis, okay? Now, some people can get it so bad that it actually comes up higher up into the bigger bronchioles, but most of the times it's in the bronchioles. You typically hear an inspiration. It's a very rattly sound, like you've all kind of felt or heard when you had a bad chest cold. And it's typically seen in pneumonias, right, which is infections in the lungs, bronchitis, which is infections in the bronchioles. Okay. Upper airway sounds, we said gurgling, which again could be fluid, secretions, vomit, blood, okay, in the upper airway. So it's kind of a kind of sound. You hear it both ways, in and out. Okay, again, it could be vomitous, it could be saliva, it could be blood. Snoring, again, we said is the tongue. And they're going to ask you on the test, they're going to say, is snoring a sign of a partial obstruction of the airway or a complete obstruction of the airway? So again, if it was a complete obstruction, that means no air is getting through, which means there can be no noise. So it's got to only be a partial obstruction, okay? And most of the times, you know, snoring is both ways, right? You hear when somebody's sleeping and they're snoring, you hear both ways, in and out, okay? Now, why do people snore from a medical emergency standpoint? They're unconscious, they're on their back, and their tongue relaxes and partially blocks up their airway. Now, why they're unconscious, we don't know, but that's the typical reason why, right? So it could be that they're not deeply unconscious, they just have a mild altered mental status. But, you know, if you're not sitting up and you're lying flat, you're probably going to have snoring. Again, we have ways of managing that, right? We have our manual procedures, our head, tilt, chin lift, on a non-trauma patient, or a modified jaw thrust in a trauma patient. We have our oral airways or nasal airways. But, you know, the long and short is, if somebody's tongue is relaxing and blocking their airway, they're not getting the same amount of air, and they're decreasing their tidal volume. They're decreasing their oxygenation. Okay, crowing and stridor, okay, is kind of a same kind of sound, but it's where the upper part of the airway, the larynx, okay, is starting to spasm, okay, or there's a blockage of some way in the upper part, the very top of the trachea, okay. So from an infectious standpoint, you have two, croup and epiglottitis we'll talk about when we talk about kids, okay. It could also happen from, you know, partial obstructions that lodge in the upper airway, like a piece of food or a peanut or a toy. You know, I once had a kid who had a piece from a Lego set that he put in his mouth because he didn't want his brother to take it from him, and he swallowed, you know, didn't swallow it, didn't go to his stomach, but he aspirated it, and it was you know, sitting in his upper airway. So he had this crazy sound. We had no idea. And 1 minute he would be fine, the next minute he wouldn't be. And it turned out that's what it was. When they took an X-ray, they saw it, and they were able to bring a ears, eyes, nose, and throat doctor in, and he went in with a flexible scope, you know, to be able to pull it out and stuff like that. Okay, anaphylaxis, again, being a severe allergic reaction, not just their skin itchy, but they're actually shutting down their airway and they're vasodilating. Remember, anaphylaxis is one of the forms of distributive shock, right? Where the blood vessels suddenly dilate. But early on, it's mainly a breathing problem. And then we'll talk about drownings, the difference between a dry lung drowning and a wet lung drowning and stuff like that when we get to that section of the class. Okay, the term auscultating means listening. Okay, so when we're talking about auscultating for lung sounds, it means we're taking our stethoscope and listening. Okay, and I'll show you the different spots that you would listen on, and we're going to listen both on inspiration and expiration. Now, a couple things. To truly listen to somebody's breath sounds, okay, and hear the differences and really know what you're doing, okay, you have to do it on bare skin. The head of your stethoscope has to be on bare skin. You cannot have it over clothing, because all you're going to hear is the sound of the clothing moving, or the clothing is going to muffle the sound. So when you see people putting their stethoscope over clothing, it is really useless. The only thing you might be able to hear over clothing is that air is coming in and out of each lung. You can't actually hear the quality of the sound. You can't say it's rails or rhonchi or anything like that. So when you see somebody listening to lung sounds over clothing, they're doing it just to give a show. They're not really doing it the right way. Okay, so that's the first thing. Then we're going to talk about how do you actually listen to, you know, breath sounds the right way on a patient. Now, in the COVID environment that we're in, you know, you got to be careful. Anything you do to make a patient exhale more or breathe harder raises your risk of catching the disease. So just, you'll see that people are not treating or assessing COVID patients the same way they are, you know, prior to COVID, because everybody's concerned of their, you know, their own safety and their own health. Like I said, Sunday night, I had a call, the family had told the 911 operator that, everybody was sick in the house with COVID. So I got the dispatch as, COVID. So when I pulled up, I actually took about 5 minutes before I went in, and I had to put on, we have a half face respirator, and then I had to put a face shield on, and then I had to put a gown on, and I had to put gloves on, in the whole 9 yards. But that's what you have to do to be able to protect yourself, so that you don't have to worry about catching the disease yourself, and then God forbid, bringing it back to your own household.
Isn't the gown just for blood?
No, the gown is because the virus lives on surfaces. So if you have it on your clothing and you're not going to go home and change your clothing, like in other words, I'm working, I can't change my clothing. So the gown is to protect you from getting it, on your clothing. The other very important thing is that the CDC last week put out a big thing that they feel the rate of infection through the eyes, the mucous membranes of the eye, is pretty high. So they put out a big thing about, glasses alone are not enough eye protection. You actually have to have a full face shield or tightly fitted goggles, okay, that fit to your eyes and stuff like that. So, yeah, you definitely have to have a, unless you're going to, shed your clothing, you have to do it. Because I mean, think about it. If the virus is on your clothing, you finish the call, and now you're at home and you're touching your clothing, and then you bring your fingers to your mouth or to your eyes, or you're hugging your kids or something like that, the virus can live on clothing for hours. So you have to, you definitely have to have a gown on. Some people go for a whole Tyvek suit, which, probably is better than just a regular gown, but the gown that you put your arms through that ties around you is more than adequate to do it. I mean, if I was doing airway procedures, where I may be causing someone to cough or gag or, spit up or something like that, I probably would want to be in a full Tyvek suit that zips up, that has the hood and everything like that. You'll see a lot of people now actually wear like a disposable hair covering besides everything else, just as another level of protection. Okay, so when we're listening to lung sounds or auscultating for lung sounds, right? So again, they're going to ask you what the term auscultation means on the test. It just means listening. They're not going to, it doesn't mean listening for blood pressure. It doesn't mean listening for lung sounds. Auscultation just means listening. We as EMTs use our stethoscope to auscultate lung sounds and blood pressure. Okay, those are the two things that we use it for. Now, when you're auscultating, the first thing I usually tell the patient to do, this is pre-COVID, is to turn their head, okay, away and cough once or twice. This is mainly the older patients, because if somebody's been sitting in a chair or laying in bed, what happens is that, stuff starts to build up in your lungs when you're not moving around a lot. So by having them cough, they kind of clear their lungs out a little bit, so that when you're actually listening now, it's not just that gunk that's been sitting down there. So, I usually tell them, turn their head away from me, cough once or twice, and then check your stethoscope, make sure that it's facing the right way, okay? If the stethoscope's cold, obviously you can warm it up a little bit by, take it off your ears, but rub it on your clothing a little bit to kind of warm it up, okay? And it doesn't matter whether you start front or back, okay? But what you want to always do is compare. So you're comparing side to side, lateral to lateral. So you're going to tell the patient, okay, breathe in, breathe out, breathe in, breathe out, breathe in, okay, breathe out. So again, the lungs are all here, right? So this is kind of what we're doing. I'm assuming the red cursor is moving on the screen so that I'm not just, talking and you're not watching what I'm doing. There's a red cursor moving on the screen, right?
Yep, laser point kind of thing.
Okay. So again, you're going to compare. Now it's not front to back, it's side to side. You're comparing each lung. So you're going to go here, here, but you tell the patient, breathe in, breathe out, breathe in, breathe out. So you know what phase of breathing you're listening to. Okay. And you work your way all the way around to the lateral side, right up on, I usually listen 2 places, high up underneath the armpit, a little lower down. Okay. And again, on the front, here and here. Here and here is a little harder to listen to for 2 reasons. You have a lot of muscle here. Okay. And also the heart is beating. So it's a little harder here, but definitely here and here. And again, you've already gotten more to the sides. Okay. And they're showing you here how you would auscultate along the sides. Okay. So all you're doing is comparing back to back. The whole thing is going to take you, I don't know, 30 seconds, at the most, to be able to listen to. But you want to listen to on the skin, okay, not over clothing. Okay, so we talked about what wheezing
On the
was.
left side, in the front, you also have, or in the back, you also have that middle one, because
on
you
the-
don't have the middle lobe because of the heart is over there, right?
Oh, what are you talking about? So in other words, when you're listening to lung, are you going to miss a lobe?
On the left side, on the right side, you have 3 lobes in the lungs, but in the
Right.
left side, you only
Right.
have 2.
Right. So there is a little notch. So really the left lung and the right lung are about the same size, believe it or not, even though you have it's just anatomically, there's not 3 separations of the lung, but it's about the same size. So you're right that there is a little bit of the heart that shifts over, kind of over about to here, right? So your heart is mainly right here, but the left ventricle kind of comes right over here, but you can still listen and hear lung sounds. Like I said, the right over here is a little harder to hear, okay? More or less just because of, you got your pectoral muscles here. And obviously in women, they have breasts, so it's a little harder to listen. I mean, in a woman, it'd be useless to listen here, again, because of breast tissue. In all honesty, you hear much more over the back and much more, okay, over the lateral sides over here on the sides. These are good for the tops of the lungs. They call the apices, but people don't usually have problems, at the top of their lungs. And again, down here, listening again to the side, and you're just coming around, catching the front of the lung. So, and you'll decide, as you gain experience on, what you're going to do for each different patient, depending on their body size. I mean, you get somebody who's 500 pounds, you can't listen to lung sounds. There's just too much meat, over them. So, you might be able to listen up here, and up here, but you can't listen anyplace else. There's just too much, covering over it. So you kind of gear your assessment towards the patient you have here. In class, we just kind of talk about generalities. The only way you're really going to, get good at assessment and developing your assessment is to get out there and start treating patients in the beginning, under the supervision, hopefully of somebody who knows what they're doing, so they can, gear you in the right way. Okay, so we talked about wheezing, we talked about crackles already and stuff like that. We're going to talk about it again and again as we go through the specific emergencies where those are the sounds that we hear. So this we all covered already.
I got
Okay.
one question.
Yes.
You as, since you got many years of experience, when it comes to, let's say you need to do, you got to do it on the woman, right? So what are you're gonna tell her? Okay, I'm gonna check your whatever. I mean, are you?
So again, real life versus, classroom. In classroom, we say, we do everything the same. Doesn't matter if it's a man or a woman, right? In real life, you got 2 issues. So you're going to be doing women and you're going to be doing, from Jewish women. So you're going to take your stethoscope and you're going to tell them, I got to go under your clothing and put it, and it's going to go nowhere. You're going to get, either hit or whatever. So it doesn't happen. I'll just be honest with you. I could tell you how it's supposed to happen, but it's just not going to happen. I mean, the first time I delivered a from Jewish woman's baby, I said to her, you got to open your legs. And she said, no. And I said, but the baby has to come out. And she's like, no. And I'm like, okay. So I said, it was before I told I had paramedics. I said, okay, well, keep on driving to the hospital. We'll see what happens. At some point it hurt so bad, she opened up her legs. But, as soon as I took the baby out, she was like pulling sheets and covers over herself, covering the baby and her. And I'm like, ma'am, I have to do things. I said, I won't look. I said, I said, I'll close my eyes and do it by feel. I don't know what to tell you, but there's things we have to do. And then when we told her after we got the baby all cleaned up that we had to deliver the placenta and we had to pull the covers back, she said, no, just let it come out. And I said, what? She goes, this is not my first baby, just let it come out. And it'll just lay there. And I'm like, well, we have to see if you're bleeding. She's like, I'll tell you if I'm bleeding. And I was like, whatever. So we went into the emergency room and they told us to go right up to labor and delivery. I went up to labor and delivery. I said, I'm sure you know what we were facing here. I have no idea what's going on with her, but here's the baby. And that was it, So I was like, whatever, she didn't want us to do anything other than be a taxi cab to take her to the hospital. If we could have, if she could have held her legs tighter before we got to the hospital, we wouldn't even been able to, deliver the baby. So it is difficult. You know, I mean, it's very difficult with the clientele that you're going to have. I mean, the other biggest problem is that, you know, in the Jewish world, nobody wants to admit that they have any medical problems. So you're going to get there and say, what kind of medical problems you have? Nothing. You know, and you're going to say, okay. And then you take them to the hospital, and then they're telling the doctor they have this and they have that and they have this and they have that. You know, and then the other big problem is they all want to go to the city. So you'll have somebody who's dying, and they're forbidding you to take them to a local hospital. They want you to take them all the way down to the city. So now you're transporting this dying patient an extra 30, 40 minutes, you know, down to the city. So you're definitely going to have more hurdles than the average EMT has coming right out of training and stuff like that.
But Frank, this was my question to you before. If somebody's not honest to you, they're never going to tell you because they're afraid or they're ashamed. How are you treating a patient like that?
So, yeah, you know,
understand my question? If you have to check, for instance, lung sound, the lady says no. I mean, well, what can you do?
You don't.
You can't,
You don't?
right? You're not allowed to touch someone without their permission, right?
Fine. So that's solved.
So-
You're going to ask her a question. Do you have any medical condition? The answer is yes, but they can tell you no. Well, what's the next step you're going to do? You know what I mean? You be in a tight position.
Right. So what you have to make sure is that when you document after the call, you say patient denied any medical history. So that proves that you asked it, right? If you just say no medical history, patient, you know, where the section that says medical history, you write none. That doesn't say whether you asked it or not, right? So you write patient denied any medical history. I even sometimes will say patient denied any medical history, patient denied similar episodes of what they're experiencing today. In other words, they, you know, if they never had this problem before type of thing. Patient would not allow lung sounds, you know, patient would, you know, I mean, there's just, you know, you just have to paint the picture when you're documenting. You have to, you know, document as clearly as you can the obstacles that you're facing. And, you know, listen, I'm sure, you know, that it's the same thing is going to be going on into the hospital, you know, especially if you're taking them to a hospital. They, you know, again, they're going to only want to be talking to their doctors. So they're going to come into the emergency room. There's going to be nurses and emergency room doctors. They're not going to really want to, you know, talk to them. So it's just a cultural, you know, obstacle that you face, you know, so. Okay, so again, when we're talking, we're still staying on the trouble breathing. We said the pulse can go either way. Early on, it typically goes up, but if they're very, very, very hypoxic, if their oxygen level is very, very low, since the heart is not getting the fuel it needs, it's going to decrease. Obviously, initially, their respiratory rate will increase to compensate, but if you see it starting to slow down slower than normal and the patient's mental status is decreasing, that's a sign that they're going to stop breathing on you. Again, rhythm-wise, most of the times people having trouble breathing breathe regularly. Rhythm means the time between each breath is the same. The only time you're going to see irregular breathing is if with a head injury. Now, I know some of you were talking, sending me texts and stuff about like, why does the heart rate slow down and why does this happen and why does that happen when somebody has different types of head injuries? So again, Saturday night, I'll set up a little review session and we can go over all those questions you have from the trauma sections and everything like that. You know, talk about why you see all the different things you see and clear up whatever questions you have, okay? Typically with breathing problems, okay, the blood pressure most of the times is high because they're scared. And again, when you're scared, adrenaline is secreted. And when adrenaline is secreted into your bloodstream, your blood vessels constrict, so your blood pressure goes up. It'd be very rare to see somebody with a low blood pressure and having trouble breathing and stuff like that. Okay, so now what do we do? Okay, so if they're not breathing well on their own, then we're going to have to ventilate them. Typically, we use the bag valve mask, we said. If they're breathing enough times a minute with adequate tidal volume, but they feel like they can't catch their breath, then we have to give them supplemental oxygen. You get the difference? One is that they're not bringing the air in, so we can't just strap a mask on their face. We have to force it into them. The other one is that they're breathing an adequate amount of times per minute, and it's deep enough, okay? And that's all subjective. That's all stuff that you have to figure out, you have to assess, okay? In that case, we can give them supplemental oxygen. Again, we have the non-rebreather, we have the nasal cannula, okay, and we have CPAP to be able to help them in those different ways, depending on the severity of their breathing, and we'll talk about all those different things. Okay, so to use supplemental oxygen, so let's see, it's 21, so we'll go to around 21:30 and we'll take a break, okay? Now we have our oxygen tanks, right? Again, oxygen in an oxygen tank is 100%. Room air is 21%. But the problem is that the oxygen in the oxygen tank has no moisture to it. And we're not designed, right, as human beings to breathe air with no moisture in it. So that's one of the obstacles that we face, okay? Now we can add humidity, but it doesn't work well on the portable tanks. It works better on the main tank in the ambulance. So we'll see that in a couple of minutes. So we have our non-rebreather as our device of choice, okay? Although a lot of patients don't like the way the feeling is. So if somebody just has some complaint of shortness of breath, but their pulse ox is close to 94%, we can get away with the nasal cannula, especially if you see after you put them on the nasal cannula that it brings the pulse ox above 94%. This is just talking about the different types of tanks. They give them a letter classification. Okay, the typical tank we carry in the ambulance is a portable tank that we bring in the house is a D tank. It has about 350 liters of oxygen in it. So all that's saying is if you were giving somebody 10 liters per minute of oxygen, you have 35 minutes of oxygen in there. That's if the tank was completely full, okay? An E tank is about the same diameter as a D tank, but it's taller, okay? So that's all that is. And then on the onboard that's in the compartment in the ambulance that doesn't, stays there are much larger tanks. They usually require like a dolly type of device to lift them in place because they're so heavy. Okay, so they can go anywhere from, nowadays there's H tanks that are huge that you actually have like a hoist to lift them in and stuff like that. And they obviously have much more oxygen in them. Then we have a regulator, okay, that is hooked up to the oxygen tank. So this is the tank and this is the regulator. Inside the tank, the oxygen is at 2,000 pounds per square inch. That's way too much pressure for a person to, whoops. I did something there that I shouldn't have done. What did I do?
Just press escape. Hit
Press what?
escape on your keyboard.
Oh, thank you. Okay, so, okay, now I was letting someone in class. So what the regulator does is it takes the pressure that's way too high for a patient to tolerate, brings it down to a safe level, okay, and then allows us to give a specific amount of liters per minute of oxygen to a patient. Now, when we're using the tubing plugs on over here. These ports are what they call high pressure ports. So those, again, when we don't use them anymore, but years ago when we were using that device, the flow restricted device, that's what hooked up to there. And that was you were able to give people oxygen at a higher pressure. So you didn't have to use the bag valve mask, but the danger is that you could, cause problems of overflating the lungs and, bursting the lungs and stuff like that. So we don't really use it anymore. Okay. So you have a dial over here that you twist and you'll see the numbers changes from 0. Some of them go 0.5, 1, 1.5, 2.5, and then typically, up to, then they go at 4, 6, 8, 10, 12. And the newest ones go as high as 25 liters per minute. The older ones used to go to about 15 liters per minute. Okay, and again, your tubing would be
The last 200 liters you don't use. Is that a difference in the sizing of the tank, or
no? So what you basically don't ever want to do is to drain an oxygen tank completely. So whether you leave, again, 200 is the textbook answer, okay, but whether you leave 10 pounds per square inch in there, or 200 pounds per square inch in there of pressure. So when you're looking at the gauge, this is pressure in the tank. This is liters per minute coming out of this over here, two different things. So the reason you want to leave some pressure in the tank, okay, is that so no moisture could enter the tank. So in other words, as long as the tank is pressurized, no moisture could get in. Again, as long as the valve was closed, this top valve, over here, right? This is the valve that turns on the tank. Okay, this over here just tightens the regulator onto the tank, this one over here, but this is what turns the tank on and off. Some of them have it built in, some of them you have to use an oxygen wrench to do. Depends on how newer the tanks are. As long as this was closed, no moisture could get in. But if this was left in an open position and this tank was completely bled empty, then obviously moist air could enter in and cause rusting and pitting. Even though they're aluminum, I mean, it could still cause issues in their bacteria and stuff like that. So that's why we always say that you don't want to run a tank completely out. But if you do, the only thing you would just do is, keep the valve closed and then fill it up as soon as you can. But on the test, you're right. You'd say typically you don't want to bring a tank down. Some people say 500, some people say 200, some people say 100, but 200's a, easy middle ground. Okay, so what he's looking at over here is
So on
that
the test, the answer will be 200.
I've never seen it on a New York State exam, to be honest with you. But 200's fine. Yeah. I mean, they're not going to, they wouldn't ask it because there's real no difference between 50, 100, 200, or anything like that. I mean, as long as there's pressure in the tank, nothing else can enter in. So, I can't picture they would ever ask that as a question on a test. Okay. So not that anybody knows about this or ever really does it. But there are dates engraved on the tank, and they're called hydrostatic test dates. What it means is that because these tanks are exposed to huge amounts of pressure, they have to be checked periodically, every 5 years, some tanks every 7 years, to make sure that cracks have not developed in the tank, that the next time you fill it up, it explodes. So what they basically do is that this silver valve that's stuck in the tank, they unscrew it and they go down inside the tank with a camera, and they look to see if there's any, signs of cracks or damage on the inside of the tank. Then they stamp a new date and you get another 5 to 7 years. So that's what he's kind of looking there. But again, you could ask anybody and nobody has any idea, nor do they know how to decipher it, because the date is not, 12/1/2020. It's not stamped that way. And then there's different symbols that mean whether it's a 5-year, it's good for 5 years, or it's good for 7 years, or it's a repeat that it's been done once already. So it's a little complicated. So usually the companies that fill the tanks are the ones that kind of look at that for you, or there's, maybe 1 or 2 knowledgeable people in every agency who know how to decipher them. Okay. But when the state inspects ambulances, they do come and look at those dates to make sure you're not carrying tanks that are not, tested, that have not been tested properly. Okay. When you look at a regulator, the only thing they're showing you is this is the part that plugs into the tank, right? So the tank is going to sit up in here. You see there's a little black gasket in here. So because it's under such high pressure, you can't have just a seal of metal on metal because air would leak out. So there's a little rubber gasket that's between the regulator and the tank. So that if that were to fall out and you were put the tank together, you would just hear huge amounts of oxygen leaking out, right? Because there's not a tight seal. And that just means it needs to be replaced. Those are disposable. They wear out. You just pop them out and put a new one in. Okay. So the first thing you do when you get a tank that's professionally filled, it'll be sealed with a piece of plastic over it, so no dust can enter into the tank. Okay. But the first thing you do is you peel away that plastic, and then this is the hole that the oxygen comes out of. You face it away from you, away from anyone else, and you quickly just turn the tank on and off. And what that does is it vents out any dust or anything that could have been right in this opening, because if that dust blows into the regulator, it'll destroy the inside of the regulator. The inside of the regulator is very delicate, and it'll destroy it. So you just vent it out real quick. Okay. Then you would take the regulator and put it on. Now, all compressed air tanks have a pin system where there's going to be pins on the regulator. Let's see if we can see the pins. Well, you can barely make them out, but there's 2 pins here. And there's going to be holes to match the pins on the regulator. So what happens is that an oxygen regulator would only go on an oxygen tank. You can't take an oxygen regulator and put it on a helium tank or a carbon dioxide tank, because the pins are lined up differently and they're in different places, and there's a different amount on every different regulator. So it's just a safety system to make sure that everything's aligned properly, and that you can only use, an oxygen regulator on an oxygen tank. So you're not picking up a helium tank and giving a patient helium by accident thinking it's oxygen, right? Not that we have helium, but I'm just saying. Okay, so that's what the pin system is. So what they're doing here, okay, venting, and it's a little hard to see, but there's the 2 little holes that those pins have to go into right over here. Okay, and again, it's just practice doing it a few times, in class and stuff like that, and you'll get it down. Now, when you tighten it on a oxygen regulator, it's hand tightened. You never use anything to tighten it more than that, because what happens is it crushes everything. And then from that point on, you always have to tighten it tighter and tighter and tighter, and it's just going to destroy everything after a while. So you never use anything, just hand tighten it. If you hear air leaking out, it's that you either didn't align it properly, okay, or that the gasket has fallen out. It doesn't mean that you have to tighten it more. Okay, it just means, you know, one tighten, like one turn of the handle once it's pressing, once you have some resistance, is more than enough to seat it if the regulator is lined up right with the pins in the right position, and if the gasket is good. Okay, so once you have it on, it's fine. There used to be a question, and there is a concern about any kind of lubricants, any kind of petroleum-based lubricants like WD-40, Vaseline, anything like that. They don't mix with oxygen well, so we never use any kind of petroleum products around oxygen. So you should never be spraying any kind of lubricants or anything like that on there. You know, not that anybody ever does, but it's just something, you know, just to mention. Okay. So now what they're doing, they're kind of obscuring it, but they're taking that top valve and they're turning it. Now, just like everything else, righty tighty, lefty loosey, which means when you turn something to a right, you shut it off. And when you turn it to the left, you turn it on. Okay, so they're turning it on. Soon as you open the valve, even a tiny little bit, because everything's under such pressure, you'll see that the gauge will pressurize up to whatever the pressure is in the tank. So it's full, it'll be up to 2,000 or even 2,200 pounds per square inch, depending on what was used to fill the tank. Okay, and then as it starts getting down, the gauge will fall down, and somewhere, see over here, red, I can't read what it is, but that may be, again, 200, 100, whatever, you know, the people who made the gauge decided was the least amount of pressure, you know, I mean, the amount of pressure you want to leave in a tank. You never want to let it get below that. Okay. And again, you twist the little control on the side here to adjust, okay, the liter flow. Here you see it's at 15, which on the older style regulators is the highest amount, but the newer ones can go up to 25 liters per minute. Okay. And again, you know, just a different view, looking straight down at it. Okay. You want to make sure that oxygen is always secured, because those are tanks under pressure. Never leave them standing up, never leave them in a situation where they could fall over. Okay, so we're using a non-rebreather. Have you guys practiced with any of the oxygen stuff yet?
Yes, we have.
Okay,
Yes.
so you know with the non-rebreather, you have to fill it up before, you have to fill the reservoir bag up before you put it on the patient's face. And that when you're taking it off, you actually remove it before you shut the oxygen off, right? So you always want oxygen to be flowing through the mask. So before you put it on them, you fill up the reservoir, make sure it's full, and then you put it on their face. And then when you're shutting it off, take it off them first and then shut off the oxygen, okay? And then you're shutting off the oxygen, okay? Bleed out the regulator. And here they're showing you taking the regulator off, but we don't usually take the regulator off if we're not changing out the tank, okay? This is a picture of a humidifier. Okay, this is a portable disposable container of water. They're pre-filled, pre-sealed. Okay, they're sterile, and you basically are taking the regular oxygen regulator in an ambulance. You're screwing off the little green bottom to it that has the part that the oxygen tubing fits on, the barbed part that the oxygen tubing fits on, and you're screwing the humidifier onto it. And then there's a little port that the tubing connects to on the humidifier to go into the patient. Once you're finished giving the patient oxygen, the call's over, that unscrews, it gets thrown away. Okay, and then you just put the green piece back on. Okay, so what time is it? Okay, we'll go a couple more minutes, then we'll take a break. Okay, so we said with the non-rebreathers, we want to fill them up first. So the way you fill them up is you put your hand over the inner gasket until you see the bag fill up. And you want to monitor that when the patient's breathing in, that they don't deflate the bag by more than 50%, by half. If they do, then you up the liter flow. Typically non-rebreathers, you know, start somewhere 10, 12 liters per minute and go as high as 15 liters per minute. And if they're tightly fitted to the patient's face, they're giving close to 100% oxygen to a patient, right? This is something called the Venturi mask, which in Rockland County, I really don't see EMTs using too much. This is something more you would see used in a patient's house. It's typically the emphysemic patient, again, the COPD or the emphysema patient, that needs a precise amount of oxygen. So this device has different fittings or a dial on here where, based on what the pulmonologist, what the respiratory doctor decides, you can give a patient a very specific percentage of oxygen. So it typically goes obviously not 21% because that's room air, but it typically goes, say, 24%, 27%, or 23%, 26%, 29%, 31%. So they can give them a very precise amount of oxygen. So if you have a patient who's on that, all you would do is take it with you to the hospital, and whatever liter flow the patient says they're on, you would maintain them on. So if they ever on a device, you would just maintain them on that device, and then just try to get a family member, to take responsibility for the device at the hospital. So just say, please, as soon as the nurses switch them or do whatever, take back your oxygen device so you have it in the house. Again, a nasal cannula gives oxygen at a lower percentage, obviously, because it's mixing much more with room air. We just have to remember how to put it on safely, okay? Which is that it never goes around a patient's neck or anything, or around a patient's head. It's always looped around the ears so that if it gets pulled on, it'll just pull right off their ears. And that you don't see it here, but there's a little piece that sits on the patient's lip so that you know which way everything kind of sits. So the prongs actually should be curved going down into the nose, not facing upwards. And you take that little piece, if it's resting on the lips, it's always facing the right way. The safest way to put a nasal cannula on and not make a mistake on putting on backwards is to face the patient, be in front of the patient, face the patient when you put it in, so you could see that the prongs are curving down into the nose, right, up and downward into the nose, and that little piece is resting on the lips. Okay. For small children, sometimes it's too scary for them to have something, pressed on their face. So we can do what's called blow-by oxygen. So you could either just take the oxygen tubing, run it at about 6 liters per minute and hold it in the general vicinity of their face. Again, here they're using a oxygen mask, just increasing in their face. My experience is that when you have a child who's been, having to been on oxygen previously for whatever reason, they have asthma or something like that, they're not scared of it. They know what it is. And a lot of times they can put it together quicker than you can. So it's really just if you're giving oxygen to a kid for the first time, it becomes a problem. Okay, so, now we're going to talk about what we can do for a patient. So, as we go on and stuff like that. But I think we'll take a break here for a second, and we'll come back and talk about the CPAP device, and we'll go through all the rest of the stuff. Okay, so it is 21:22. So come back around, I don't know, 21, 30, let's see, 30, 8 is 30, come about 35, 21:35, about 9:35, and we'll start up again.
Frank, just one question. You showed a picture of a bag with water.
A bag with water? Hold on.
No, the previous picture. Now this one. Go one before.
That?
This one.
Yes. It's not a bag. It's actually a plastic container.
What is this water for? What is this?
So again, we said that the oxygen tank, right? The oxygen in the oxygen tank has 0 humidity. And we are not designed to breathe air with 0 humidity. So it just adds moisture as the oxygen.
Oh, it adds moisture to the oxygen.
Yep. So if you've ever visited somebody in the hospital, they're always hooked up to a humidifier. Nobody should be getting oxygen that's not hooked up to a humidifier. The problem is that in the ambulance, we don't do that for some reason. It's wrong, especially in Rockland County, because we have such short transport times, we don't do it. But any patient, especially patients having respiratory problems, would benefit from having humidified oxygen. So that's just a safe device. Years ago, it was a non-disposable. It was like a cup that we screwed on and we added the water to it. But the problem was it was never cleaned between calls, so bacteria could build up in it. So then they made these disposable ones, and they're just a much safer, better way to, administer the oxygen.
No, my question is, if it's 100% oxygen, why do you need the water? Why do you need the moisture for?
Because think about it. Think about how when you're outside in the cold, in the winter air and there's no humidity, it's dry and there's no humidity, it's harder to breathe. What happens is that our airway is lined with mucus, right? Mucus is a substance that's supposed to catch the pollution. So mucus is kind of like a pasty material. If there's no moisture in it and you're breathing real fast, or that oxygen in and out, what are you doing to the mucus? You're drying it out and you're making it turn into like glue. And then it clogs the airway, it clogs the bronchioles, and you can't get good gas exchange. It actually obstructs the airway. So it's very dangerous. So that's why really anybody, adult, child, anybody having trouble breathing, having a respiratory problem, should be given humidified oxygen. Even though our transport time may only be 10 minutes, they still should be given. We can't give it in the house, so we can only give it in the ambulance. And we don't. I have to be honest with you, in Rockland County, you know, because of the most times a very short transport time, people don't bother doing it. They just figure they'll be at the hospital the time the patient is on it, even for 5 minutes. And yeah, that may be true, you know, in say the Ramapo area, that may be true in the Nyack area. But, you know, like I said, in the hospital, you'll never see a patient that's not on humidified oxygen. Okay, so go take a break for a few minutes, stretch your legs, and we'll come back. Okay, so we're going to talk now about CPAP.
Don't EMTs carry a device that alerts them that there's carbon dioxide where they are?
Right, that's the RAD 57. I said that every ambulance got one issued by the county. So yes, every ambulance corps got one, but the problem is that some ambulance corps have more than one ambulance, and you know, that may not be the ambulance that responded that has it, but all the paramedic trucks have it in multiple different ways. So there's definitely a way in the field of, you know, getting somebody on the RAD 57. Okay, so I skipped ahead a little bit just because I wanted to show you the device first, so it kind of makes a little more sense. So CPAP is a tightly fitted mask that goes on a patient that has a device that basically increases the pressure of the oxygen coming into the patient and makes it a little more difficult for the patient to exhale. So by increasing the pressure in, right, when they breathe in, it kind of inflates their bronchioles and their alveoli a little more than, say, them breathing on their own. So that one of the situations we use CPAP for is somebody who has congestive heart failure that has fluid in their alveoli. So it actually helps to get that fluid out of their alveoli. And an asthma patient actually helps to keep their alveoli, I'm sorry, their bronchioles expanded, because we said asthma is a problem where the bronchioles constrict. So again, so one thing it does is it pressurizes on the way in. By making it a little harder for them to exhale, there's a valve in here that makes it a little harder to exhale. So what happens is when you make it a little harder to exhale, remember I said that the COPDers sometimes breathe with what they call pursed lips, and it was to make it a little harder for them to exhale to keep their airway expanded. The same thing, that this device forces the airways to stay a little more open than they normally would, because it doesn't let a patient fully exhale all their air. So that combination of bringing more air in under pressure and keeping the airways expanded a little more than they would be makes it easier to have gas exchange, makes it easier for air to come in and out. So it is a great device. The problem is with it, when somebody's short of breath and you strap this big, huge device over their face, it makes them freak out. I have to be honest with you. It just makes them so scared, okay, with this thing sitting on their face with pressure, okay? Now, it's better than non-rebreather, because what happens is if you could convince them to start, just breathe with it, suck the air in. When they go to breathe in, it actually, I don't want to say forces air in, because it's not like a bag valve mask. It doesn't breathe for them. But since there's pressure behind it, they feel like, oh, it's kind of like, it feels like it's helping you breathe. Okay. Now it is a little harder to exhale. So some people you may see, like all of a sudden when they go to exhale, their eyes will get a little wide, and you say, just exhale, just keep on going, and now breathe in. Okay. So don't worry so much about exhaling as worrying about breathing in. Okay. And you have to kind of coax them, and you have to be with them, and you have to hold their hand and get them to do it. But once they breathe for about 2 or 3 minutes with it on, they'll get used to it and they love it. It really makes their trouble. I've had patients who look like they were dying. I mean, sitting up scared, you know, pale, sweaty, just looking so scared. And we were able to convince them to keep it on. And by the time we got them to the hospital, they looked like they were 100% better. And to the point where the doctor's like, well, they don't seem so bad. You know, you made it sound like it was so horrible. Well, yeah, in the house, they were bad, but, you know, we made them better with the CPAP.
This is a non-rebreather or a rebreather?
No, it's a completely separate device. It does not mix with outside air. So it's 100%, you know, non-rebreather. There's no outside air coming into it. It's basically 100% oxygen, because for you to get the pressure, the mask has to be tightly fitted. You see how there's this huge strapping system on the patient's head?
Yep. This
is kind of pressed very firmly on the patient's head. Now, this is just one manufacturer's version of it. It's actually not the one we use. It was one of the earlier ones that got out there. Ours is a little more comfortable, but it has even a better strapping system. So it even looks crazier as far as the strapping goes, because it's got this whole black net that goes behind their head. So, you know, but they all have the basic same concept, which is it has to be tightly fitted. Okay, a very good seal. And then it has this pressure valve that does not allow them to fully exhale so that it keeps their airways expanded. So let me go backwards and now we'll explain a little bit about it.
You treat COVID patients this way as well?
So they tried COVID patients, they thought the same thing. They thought pushing more air into them would make them better. That's why they put people on ventilators and stuff like that. So ventilators definitely did not help. CPAP, the jury's kind of out. It's not 100% certain if CPAP is beneficial or not. Most of the times with people who have COVID, it's more the inflammation that's going on than it's the actual breathing problem. And if you calm down the inflammation, everything tends to be better. So they're really kind of getting away from the airway treatments more to giving drugs that calm the inflammation. It's more of an immune response. Your immune system is the part of your body that is designed to protect your body from infection. But what happens, COVID tricks it somehow to think it's much worse than it is. So the immune system over responds. So it's, again, I don't think we're really going to know everything there is to know about COVID for probably 5 or 10 years from now. So they're, every day what they say to do kind of changes. But the thing they've been having the most results with is, again, giving drugs that kind of relax the immune response. But, like saying that, you could try it. And if they don't get better, you just stop it, right? I mean, that's anything you try, if it's able to be stopped, it's not a big deal. You try it and they're not feeling better and they're not getting better, then you stop it. Okay. So what CPAP stands for continuous positive airway pressure. Okay. So again, it kind of described what I was talking about. Continuous means all the time. Positive means that it's, going in and it's pressure in the airway. There is a thing you may have heard called BiPAP. So instead of C, it's BiPAP. The difference between BiPAP is that it cuts the pressure on exhalation. So it's not continuous. So on the way in, it's high pressure. On the way out, okay, it cuts the pressure a little bit. That's tend to be used on older people and on young children. But the issue is that this CPAP we have is disposable and can run off an oxygen tank. There is no BiPAP that can run off a simple oxygen tank like that. It requires the whole system, so it doesn't really work well on an ambulance. So that's kind of why we use CPAP. Okay. So again, what it basically does is keeps the airway pressurized. So it stops the alveoli and the bronchioles from collapsing when the patient exhales. Okay. Which again, doesn't usually happen in us. But again, if somebody has certain breathing problems, specifically that emphysema, that could be a problem. And it also prevents fluid from building up in the alveoli if they have that congestive heart failure, pulmonary edema type of situation. Okay. So it's a very useful device. The downside again is that the patient does not a lot of times tolerate it because it makes them feel more scared and, more apprehensive than, not having anything on their face. But again, after a few minutes of, us convincing them, it usually helps them. Okay. So where do we usually use it? Okay. Pulmonary edema, congestive heart failure, fluid in the alveoli, asthma, COPD. Okay. In asthma, the airways are tight. It helps to open them up. In COPD, the alveoli are collapsed. It helps to open them up. Now,
What does COPD stands for?
Chronic obstructive pulmonary disease. So chronic means long-term all the time. Obstructive means there's a blockage. Pulmonary is the lungs disease. Chronic obstructive, it's just a fancy word. Really, there's two types of it. There's emphysema and there's chronic bronchitis. We're going to talk about it. I keep on saying soon, but I'll just tell you it's going to be tomorrow because judging by the speed that we're going, we're not going to get to it tonight. Now, respiratory failure, I put in general here, and I probably would like to change that because respiratory failure means that somebody's getting so tired, having trouble breathing for so long, they're getting so tired that their mental status is starting to decrease. And CPAP only really works on a patient who's awake and can work with the machine. If they're starting to fall asleep because they're getting so hypoxic, so their oxygen level is dropping and their carbon dioxide level is rising, really it's the bag valve mask. So it may help prevent them from going into respiratory failure. But if they're actually in respiratory failure, it's too late for CPAP. You need to use the bag valve mask. Okay, so again, contraindications when we would not use it. So severely altered mental status, again, where they're basically not awake, right? They're not able to follow commands and work with the device, okay? That they're not breathing on their own, right? This is not a ventilator. If they're not breathing on their own, they have to go on CPAP. Now, here it says inability to sit up, but they really mean again towards mental status, that if they are so out of it that they're lying flat, then it doesn't work, right? Because again, no patient who's having trouble breathing is going to want to lie flat. So if they're lying flat, it means that they're not awake enough to know they're having trouble breathing. Now, this hypotension and shock, again, most people having trouble breathing, their blood pressure is high because they're scared and adrenaline is released. But here's the reason why. And they define that as a blood pressure less than 90. Here's the reason why. If you take somebody who's got a low blood pressure, okay, and you put them on CPAP, think about what's happening to the pressure in their chest when they're on CPAP, right? So we all have a certain pressure inside our chest. It's called intra. Intra means inside of, intrathoracic, okay? So chest is thoracic. So intra, pressure inside the chest, okay? The lungs are inside the chest, right? So pressure inside the chest cavity. The heart is inside. The blood vessels are inside. The lungs are inside, also inside your chest. If you now put a device on them that increases the pressure inside their chest and their blood pressure is low, okay? What happens is the superior and inferior vena cava, right? The two big veins that bring blood into the right side of the heart, right? Those blood vessels, even though they're large, they're veins, and they have the lowest blood pressure of anything in the body because they're bringing blood at the very end, right? It's the last blood vessels before you get back to the heart. So the blood pressure in those vessels are pretty low. Now, if you increase the pressure in their chest higher than the pressure in the blood that's in those vessels, the blood doesn't flow. So this is why they say that if the systolic blood pressure is less than 90, that means the venous blood pressure, right? Systolic is arterial blood pressure. So that means the atrial blood pressure is probably somewhere around 20, 30. Okay, now if you're increasing the pressure in their chest higher than that, you're not going to get blood back to the heart. If you know how a pump works, if the pump doesn't get fluid in the back end, it doesn't have anything to pump out the front end. So if you increase the pressure too much, you actually stop the heart from being able to beat effectively by increasing the pressure. I've never seen this, but it is a true issue, which is if somebody's blood pressure is low, CPAP is contraindicated. Contraindication means that you would not use it, right? Okay, nausea and vomiting, I think you could picture what would happen, right? We have a tightly fitted
Same thing
mask.
could happen by bagging too. If you bag too
could,
much.
but it really doesn't typically happen by bagging unless you're really not paying attention. Right here, we have no control over it. Right. In other words, it's like the machine is doing it. So with bagging, you feel through the bag valve mask, some semblance of pressure if you're squeezing against too much. Right. So, could it happen with a bag valve mask? Yes, but it doesn't typically happen as often as with CPAP. Okay. Now, nausea and vomiting issue would be is that, you saw that was a tightly fitted mask that I said is kind of forcing air into the patient. So if they're going to vomit into that mask, and it's forcing air, what's going to happen to the vomitus is they're going to aspirate it into their lungs. So we don't typically use CPAP on somebody who feels nauseous, feels vomiting. And it's something to think about. I don't know if any of you have been in the back of an ambulance yet, but it's very easy to get car sick in the back of an ambulance, especially if you're sitting on a stretcher facing backwards, because we're not designed, right, to be in a moving vehicle facing backwards. The only reason they put ambulances like that is that it's safer for the patient if there's an accident. So you could take somebody who's mildly nauseous, right? They're not very nauseous, put them on CPAP, and then put them in the back of the ambulance. And if somebody who's driving is driving like an animal, okay, you all could be sick. But the problem is they're going to have the CPAP on. If they vomit, there's a good chance they could aspirate that vomitus. Okay. They write, do not use it in trauma. Well, obviously, that would be, everybody should say, of course, because we said that we only use it on medical problems. But one of the reasons why they're stressing it is you learned, the other day, as far as chest injuries go, that there could be issues where there's holes in the lung, right? Pneumothoraxis. So if you put somebody now on higher pressure and there's a hole in their lung, it's going to leak out of that hole and cause, many more issues, whether it be a tension pneumothorax, whether it be subcutaneous emphysema, any of these problems. So we never use it on trauma, but you should never think to use it on trauma because it's a device for a medical patient, right, who either has congestive heart failure, asthma, COPD, something like that. Okay. So again, we said nausea and vomiting, chest trauma, we wouldn't use it on. Shock, again, because the blood pressure is too low. Upper GI bleeds because they're going to aspirate, right? If they have a bleed where they're vomiting up blood, again, we would never think to use it on any of this because it's not the indications, right? The indications of somebody having a breathing problem. None of these things are breathing problems. Now, conditions preventing a good mask seal. So here's the deal. For CPAP to work, you cannot have facial hair. Okay, so somebody who has a beard or even a mustache, mainly a beard, and it can't adhere to the skin, the mask can't stick to the skin, you're not going to generate the pressure under the mask that you need. In saying that, right, of course, in Israel, where they face many more patients with facial hair, They did develop a CPAP that kind of wraps around and you tuck the beard up into it and stuff like that. I think they actually have it in KJ. I remember teaching there about this, and they said they had something. But if you have somebody with a fairly bushy beard, CPAP is not going to work on them. Okay, the typical CPAP is not going to work on them. Just like you'll have a harder time using a bag valve mask, on somebody who has facial hair, because you can't get a seal, with the mask. So that's just I wouldn't say it's a contraindication, but just to realize that it's not going to work. I mean, you're not going to get you could try it, but you're not going to get the same benefit from it. Now, the side effects are, again, it could drop the blood pressure. You could take somebody who has good lungs and cause a pneumothorax, right? It's just an acceptable risk. Okay, sometimes it does happen. Okay, again, there's an increased risk of aspiration if they were to vomit. Remember, aspiration is the term for getting something in your lungs other than air, right? So anything else besides air that goes into your lungs, the term is aspiration. If it's coming from the outside in other words, if it's coming from your mouth down into your lungs. I mean, sometimes people get pneumonias, right? They have infection in their lungs. That's not aspiration. Aspiration means that it's coming from the outside through your mouth into your lungs. And again, the only thing that should be coming into your lungs from the outside should be, air, oxygen. Okay.
Now, what is the pressure that I do on a CPAP? There's a maximum, there's a low amount. How
Yep,
do I
I'm
set
going
the pressure?
to talk about all that in a second. Now, the drying of the corneas are the covering, the moisture on the cornea are the covering of the eye, right? So if the top of where the mask is, okay, is not fitted well, what happens is this air starts blowing out from the top of the mask and it hits the eyes. So if you see them going to the hospital with their eyes closed, okay, you could say to them, is the mask, they can't talk to you, by the way, when the mask's going on, and they probably can't hear you very well. Okay. So again, I'll try to get one and give it to David to show you guys in class, or actually Hatsola has them in New Square, but it's a good device, but it has a lot of issues around it. So you can't talk to them, they can't hear you, and they cannot talk to you. So it's all kind of sign language to be able to, but if you see them going to the hospital with their eyes closed, it means that it didn't seat well up here and the air is leaking out and hitting their eyes. And it would be kind of like somebody taking a hair dryer and blowing it on your eyes. You'll normally close your eyes and they'll dry out if you don't. So that's one of the things that, can happen with it. Okay, so now what do we do to use it? Okay, so we have to explain to the patient, right? You have to explain to them that we're going to put this over you. It's going to feel a little claustrophobic. It's going to feel a little weird, but it's going to help you breathe, but you got to leave it on for a minute or two. And remember, for us, a minute or two is not a long time. For them, having trouble breathing, a minute or two seems like an hour. Okay, but you have to hold their hands, talk to them, breathe in, let it work. Okay, now exhale, breathe in, let it work. Just calm down, work with it. I know you're scared, keep on working with it. And, be right in front of their face, look at them, say, I'm going to help you, and work. It doesn't, some people take it where they tell the patient to hold it on their face to start with, but if it's not tightly adhered to their face, it cannot make the pressure, and nobody's going to press it tight enough to have it down there. I mean, it doesn't have to be tight where it's painful, but it has to be where no air is leaking out. Okay. Now, somebody asked about pressure, right? So PEEP stands for positive end expiratory pressure. It's not a test question. So positive means, again, pressure, end at the end of exhalation, expiratory pressure. So what they're saying is that when the patient goes to exhale, they have to exceed 10 millimeters of mercury pressure to be able to force air out. Normally it's 0, right? Okay, so normally we have about 0 pressure to be able to exhale. So what we're doing is we're just increasing the pressure that they have to exhale. Again, what does that do? It keeps their airway, and including their alveoli, their bronchioles and their alveoli, expanded so that it's easier for them to move air in and out. Okay, it's not a good long-term thing. Like somebody that's on PEEP for a long period of time, you can change the way the lungs work. So it's not a good thing, but for the short term, a couple hours, day, it's not a bad thing for a patient. Okay, and they could always adjust the pressures up or down as you need them. Like as paramedics, we can go as high as 25 if we need to. So 10 is not terrible. I taught a class recently where people said that for CPAP at home that they have for sleep apnea, they were doing 15 or 20. So 10 is not a high number, right? So it's not a terrible number. You don't have to really fear doing any damage or anything like that. Okay, so again, we're going to explain to the patient what's going on. Okay, so this guy is obviously in a tripoding position. He's very anxious, right? He's, and we're going to go. Now, the other thing I forgot to mention, these older style CPAPs had a limitation where you couldn't give them albuterol through it. The newer ones, you can actually give them albuterol at the same time you're giving the CPAP. So that doubly helps because now the medicine, the albuterol, hopes to open their airway. And by giving it under pressure, you're actually forcing the albuterol down deeper into the lungs than a lot of times they would normally breathe it themselves. So that's another advantage now of CPAP. Okay, so again, just because you put it on them doesn't mean your job is done, right? So you have to constantly monitor the patient. And if you see them getting worse, you take it off and put them on a non-rebreather. There are going to be some patients that just don't tolerate it. There are going to be some patients that get so nervous and so scared and they actually get worse. You just take it off them, okay? Now, on the New York State protocol, they don't let EMTs raise the level of pressure, okay? Some states do, but in New York State, they don't let it. So you're stuck at 10, you're going to put it at 10 and you maintain it at 10. So you cannot change the levels of pressure or anything like that on it. Okay. Now we're going to reassess the patient, mainly looking at their blood pressure. I personally, when I use CPAP, I wait till I get them out in the ambulance, unless there's no ambulance. So we get there first and there's no ambulance coming quickly, then I may put them on CPAP. But if the ambulance is there at the same time that we are, I'll put them on a non-rebreather, move them out to the ambulance and do CPAP en route. Moving a patient, especially in a stair chair down the stairs and stuff like that, is very scary. And it just makes their breathing worse. So when they're on CPAP, it just scares them even more. So I just usually wait. And the other issue with CPAP is that it is using a lot of oxygen. So that if you start them on a D tank and you get stuck where you can't move them quickly, you're going to run out of air. So I usually just keep them on a non-rebreather in the house. And then when I get out to the ambulance, I put them on the CPAP for the ride to the hospital. I wouldn't even bother with CPAP, unless I'm more than 10 or 15 minutes from the hospital. You're not going to see the benefit. Then I would just get them. If I'm 5 minutes from the hospital, I'm around the corner from the hospital, just get them to the hospital, let them do it there. Don't delay. Remember, we're never supposed to delay the time it takes the patient to get to the hospital to do treatment. We're supposed to enhance the time by doing stuff for them, but we're not supposed to delay. So you should never stay on the scene to do things, okay, if it's going to delay you from transporting the patient. Okay, so again, if CPAP deteriorates, either put them on a non-rebreather, or if they need to be bagged, you bag them and stuff like that. Okay, in other words, this is showing them that they're actually getting worse. Like, so obviously that guy who we thought looked pretty legitimate before was actually a staged actor. Okay, so that's CPAP. Now, artificial ventilation. So this means we are forcing air into them. So up to this point, we had the non-rebreather, we had the nasal cannula, we had the Venturi mask, and we had CPAP. Those are for people who are breathing on their own. Okay, did I not let somebody in? Please let me in. Okay, I think everybody's in.
I tried to get in my computer.
Oh, okay. So now positive pressure ventilation means that we are forcing the air into someone. Now CPAP, remember, requires a patient to be breathing on their own. So it's not considered positive pressure ventilation. Even though there is pressure, when they talk about positive pressure ventilation, they're really talking about the bag valve mask. Okay. That's us ventilating somebody who's either not breathing or breathing so shallow or so slow that they need to, put everything, we have to put it into them, because just strapping an oxygen mask onto them would not be enough. Now, we have 3 ways. Again, mount the mask is the pocket face mask. On an ambulance, you're never going to see that being done. That is more for like lifeguards or, I don't know, people that don't have the right equipment to ventilate a patient. But I wouldn't say it's a terrible thing if you're going to be the kind of person that would, treat somebody without having a bag valve mask. At least it's better than putting your your mouth, on a patient to ventilate them. So, it's not a bad thing, but it's not the best thing. Okay, so mouth to barrier device would be those little pocket CPR shields that you see given away. So again, nobody uses those. So we have the bag valve mask. So that's the way we typically ventilate a patient who is not breathing. Okay. Now, what's the difference between, normal ventilation and positive pressure ventilation? Okay. So in other words, when somebody's breathing normally versus us forcing air into them. So, the first thing obviously is most of the times they're probably moving more air than they normally would be. That could be a good thing and a bad thing, right? So we want to kind of try to mimic the amount of air they would be breathing, which is why they're going to ask you on the test, how do you know when you're delivering enough air using a bag valve mask, enough tidal volume? And that is that you want to see the chest just start to move. Sometimes they see chest rise. They'll say the chest rising, right? But typically when we breathe, we barely see our chest moving. So when you ventilate somebody, you want to just see the chest start to move. And that means you gave a right amount of air. The reason why you don't want to overventilate, we said, is that it could interfere, right, with blood movement, like we talked about the filling of the inferior and superior vena cava with CPAP, right? So same thing with a bag valve mask. You could cause a pneumothorax, right? Or your esophagus, your food tube, right? Now, when you're using a bag valve mask, you're putting it over their mouth and you're blowing air into their oropharynx, right? When you get down deeper into the pharynx, deeper into the throat, there's two tubes. The front tube is the trachea, the back tube is the esophagus. So really you should say to me, well, 50% of the air must be going into the trachea and 50% of the air is going to go into the stomach, which means that I'm going to make the patient vomit because I keep on forcing air into their stomach. So the way we were made actually is that your esophagus is not an open tube. It's a flat tube. It's actually a tube, but it's collapsed. Okay. And that when air touches it, it opens up. I'm not air, I'm sorry. When food touches it, it kind of opens up and kind of grabs the food and starts moving it down. So most of the times when we're breathing, we don't generate enough pressure to get any air down our esophagus. But if that pressure exceeds about 15 millimeters of mercury, okay, you'll start getting air down into the stomach, okay? Especially if the patient's unconscious. If the patient's conscious, it's not such a big deal, but if the patient's unconscious, like when you're using the bag valve mask, okay, you could start getting some air just because they're relaxed and everything like that.
Wouldn't the patient start coughing?
So not that they're going to cough. Cough is something with the lungs. This is going into the stomach. Now, the problem is if you get air down into the esophagus, air goes into the stomach. And once the stomach gets pressurized, what's going to happen? They're going to vomit. And then you have the whole risk of aspiration. So that's why when we bag someone, that's a risk that we have greater than when somebody's just breathing normally on their own. Okay. Now you've seen like when kids cry, right? Sometimes when kids cry, you see their belly start getting distended, start getting swollen, because when they're crying, they're bringing air under much more force, and they're actually sucking some air down into the stomach because they're bringing that air under force, right? So that's just, again, the kid's crying. It's not an emergency. It's not a risk. Although I did one time have a kid who was crying so much at a party that he did vomit. And that, again, everybody thought it was a big deal, but that was just the extra air in his stomach forcing the food out. Probably was also, you know, the fact that he had like 5 pieces of pizza, and the reason he was crying was they told him he couldn't have any more. So, you know, that was probably a combination of everything, but, you know, he was conscious, he vomited, he didn't aspirate. It was no big deal other than, you know, somebody had to clean up the vomit. Okay. So this is the pocket face mask that you know already, right? So it has a one-way valve so that what goes into the patient, okay, doesn't come back out. When it comes back out, it actually comes out the bottom here. It has a filter so that if the patient has any kind of viral diseases, it doesn't come back up into the mask, but it's not a great device. Some of them have a port on them. I don't see it on these, but some of them have, oh, they do right here, has a port so you could add supplemental oxygen to it. Some of them don't. Obviously, it'd be better to have the port that has supplemental oxygen on it, okay? Obviously, the problem with it is that you get tired quicker because you're not only, you know, treating the patient or helping the patient or doing CPR for the patient, but you're breathing for the patient and you get, you know, tired and stuff like that. So, okay. So why on the test would they say it's a great device? Because you're holding 2 hands on it when you ventilate. So you have a 360-degree seal around it. Okay. So you make a nice tight seal. Okay. And there's going to be less air leakage and stuff like that. Also, you can get an idea of how much to breathe into the patient, because once you feel force, you know that their lungs are filled. Again, I've never used one on a patient. I've only used it on a mannequin. I never intend to use one. So I can't really talk to you from experience with using them or anything like that. I have seen go on calls where security guards, lifeguards, you know, the gym, the people working in gyms and stuff like that, I've used them. I never asked them, you know, did they think it worked or anything like that. But, you know, again, you could hold a 2-handed seal around the mask and you're ventilating the person. Now, if you're by yourself, obviously the problem with doing CPR is that you have to now let go of everything, go to the patient's side, do chest compressions, and then come back. So it doesn't really work well for one person CPR. You can try to do it by kneeling on their side, but it's a little harder to make a seal and stuff like that. These are the barrier devices. These are called like CPR masks. They're usually packaged in a little keychain type of device. They're tightly packaged into a little square, and then you open them up and There's usually a valve right in the middle that you breathe through. Obviously, again, if you're the type of person that would do mouth to mouth on someone, it'd be better to have this than it would be to, put your mouth on someone. Obviously, again, in this environment of COVID, you should not be putting your mouth on anyone, even with a barrier device or a pocket face mask or anything like that. Okay, so the bag valve mask has a couple of things. It has the bag. It has a valve that lets air go this way, but when it exhales, it doesn't come back into the bag. It actually vents right underneath here out into the atmosphere. So that you're not mixing the patient's, low oxygen level air back into the bag. And it has a reservoir so that you could give 100% oxygen. The way the reservoir works is that there's oxygen tubing that connects to this. Once this bag is filled with 100% oxygen, it starts to fill this bag, so that now when you squeeze this and empty the oxygen that's in here, it fills with the oxygen that's in here, and it doesn't mix with the room air. If you didn't have oxygen, then it will just fill through here with room air. Okay, so if you don't have oxygen, it's still better to ventilate somebody with a bag valve mask, giving them 21% oxygen from the room, than it would be not to ventilate them and let them die, of hypoxia. But ideally, we put them on oxygen. I wouldn't delay starting to ventilate somebody who's not breathing to get the oxygen hooked up. I would start ventilating them with room air. And once somebody else shows up and you can get the oxygen going, that would be fine. So, you don't have to delay the starting of ventilations to get the oxygen tank hooked up. Now, if you're by yourself, what's that?
I think on the test you should ventilate before you hook on the oxygen. That's what.
Yep, absolutely. So yeah, in other words, you would never delay starting to ventilate somebody to get oxygen running on them. Absolutely not. Okay. So this is showing you if you're by yourself, and this is called the OK way, where you got two fingers, your thumb and another finger up on the mask, and then these three fingers on the bony portion of their mandible. Remember, the mandible is a term for the lower jaw, and they're going to ask you what's important about the lower jaw. The tongue is attached to the lower jaw. So somebody who has a fracture of their lower jaw is going to have a hard time keeping their tongue up out of their airway, as far as facial trauma and stuff like that goes. And this is the most typical bag valve mask that most people have. It's called an ambu bag. And there's the tubing, okay, coming in. You will not always see this reservoir fill up with oxygen, like where it's a huge bag of it. And don't make yourself crazy. We typically run a bag valve mask at 15 liters per minute. I wouldn't go much higher, because what's going to happen is you'll just exhaust your oxygen so much quicker. So if you had a regulator that actually went to 25, I wouldn't bother. It's not so important that this fills up, because the first oxygen that's coming in is filling this up. It's always trying to fill this up, and only when this is fully filled does it go back into here. So again, when you're squeezing this has between 800 and 1,000 mLs of air in it. You only need 400 to 500 to ventilate a patient, so you should never be emptying the entire bag valve mask into someone unless you have a terrible seal with the mask and you need to give extra to just get enough into the patient. So that's why you don't have to worry about seeing this filled up, because this is more important to fill up than the reservoir is. Okay, again, it's got a valve. There's a little exhaust port over here, so when the patient exhales, it comes right out. So you don't have to actually take it off the patient to let them exhale. This is the better way of doing it, where it's two-person CPR, where one person is wrapping their hands around the entire mask, again, having their fingers on the bony portion of the mandible, doing their head tilt chin lift, and the other person is squeezing the bag valve mask. So this person here is going to have to squeeze a lot less than this person here had to, because this person has a leak on this whole side of the mask because they can't really get any pressure on it, where this person has 360 degrees around it. So this guy's going to have an easier time at squeezing the bag valve mask. Okay, so what happens if you're not seeing good chest rise and fall? Okay, it's probably because you have the mask on improperly. There's not a good seal, so you just have to readjust the mask. Okay, it may be that you forgot to hyperextend the head, but you just have to reassess what you're doing and make sure that you have a good tight seal and you have the airway open. You may want to insert an oral airway, a nasal airway, whatever, to help keep the tongue up out of the way. Or maybe they have an airway obstruction that you didn't know the reason they weren't breathing is they have an air obstruction. So in that case, you're going to have to start CPR on them to see if you can clear the obstruction. So it really depends. Now, this is a device that said we didn't use anymore, the FROBAB, the flow restricted oxygen powered ventilation device. We don't really ever use it anymore, but you see this big green hose that hooked up to those high pressure ports that I showed you on the regulator. Okay. It's the only thing that hooks up to them. unless you're using an actual ventilator. If you're on an ALS ambulance, you're using an actual ventilator. Okay, but so we don't really use them anymore. But what basically happened was there was a button. You see this little green button up here. When that person pressed that button, air would flow into the patient until that person stopped pressing the button. So the danger was that people were causing pneumothoraxes. They were getting too much air into the patient because they weren't paying attention. And, you know, it was a disaster. It really was. If you knew how to use it, it's a great device. Okay. But, you know, it was not used very well in the field. So they kind of, I wouldn't say nobody uses it, but it's not a common thing to use it anymore. Okay. So that's what that one is. Okay. So again, it was a regular bag valve mask. Onto this, that button is up over here. And when you press that button, it would go this button right up here. Air just flows under pressure into that patient. Okay, that's it. Okay, patients with stomas. So I have not seen a patient with a stoma in years. I don't know if anybody else has. It's probably been at least 5-6 years I've seen somebody with a stoma. This was very common when people had tracheal cancer or laryngeal cancer. Your larynx, the top of your trachea is about right over here. And it was typical from laryngeal cancer, which is again caused by cigarette smoking or exposure to occupational chemicals. But again, there's not as many people smoking. And industry-wise, there's much more enforcement from OSHA on using respirators. So you don't really see it anymore. So these people had cancer of their larynx. They had to remove their larynx. And they took the trachea, the tube, and sewed it to an opening on their neck. So now they would breathe through this opening in their neck. Okay. So to ventilate them, since this is not connected anywhere now, right? This is only connected to their stomach now, their throat. You had to ventilate them through there. Okay. So really, any mask that would fit on their neck will work. This is showing it as a pocket face mask. I don't know why, but you know, any mask would work to be able to ventilate them. The amount of pressure that you would have to squeeze the mask is much less because you don't have to fill this whole area up, right? You're going basically trachea right to lungs. Patients can cough through this, so you had to be always very careful because stuff can come shooting out of this hole, mucus and stuff like that at any point, you know, as far as disease prevention, infection control and stuff like that. This is a stoma. There's no plastic device in here, okay? This is actually a tracheostomy where there's a, excuse me one second, it's my bedtime. There's actually a plastic device that the bag valve mask fits on over here, or a ventilator fits on to be able to ventilate them. This is because they surgically removed the top of their trachea and then they took the tube and sewed it to here. This is somebody who needs either short-term or long-term ventilation support by a ventilator, but they didn't have any disease that required their trachea to be removed. They just do this so that their mouth is open so they could still eat and talk, okay, and stuff like that. So this is not, this first one is more because of cancer diseases. This is somebody who maybe, I don't know, had a stroke or had some kind of problem where they cannot breathe on their own anymore and they need a machine to breathe for them. This is easier for us to ventilate because we can actually hook the bag valve mask up right to it. This is not that difficult, but you know, again, it's a mask sitting onto their throat. So it's you know, a little more challenging. Okay. Again, very little pressure needed to be able to inflate their lungs. And most of these patients are not going to be home. They're going to be in nursing homes and they're going to be on ventilators and they're going to call for paramedic level ambulances to transport them and put them on actual machines to breathe for them because it's felt to be safer as far as you can adjust the pressure so the machine does not overventilate them. Okay. Dental appliances. So we're really talking about dentures, false teeth, right? So if you've ever seen what a person who has dentures, if the dentures are not in place, if you ever see what the opening of their mouth looks like, I don't want to be gross, but it actually looks like you can take your entire fist and shove it in their mouth and not touch anything. So the problem is that there's no place for the bag valve mask to sit on if those dentures are not in place. Okay. So if the dentures are there and they're in place tightly, which they usually are, you just leave them in place. You wouldn't even know they're dentures. Okay, but if you get there and you notice that sitting alongside the patient's bed, you know, on their nightstand is a glass with teeth in them, that means that they took them out. So if somebody could put them back in, it would be better. Okay, but if not, then you have to transport them without. It only becomes an issue if you have to ventilate them. And again, it's pretty rare that we ventilate people, so it's not a problem. Do not transport people's dentures yourself to the hospital. They cost thousands of dollars. And if they get lost, again, you're responsible for them. So if the family wants them to go with the patient, the family should take them with the patient if they can't put them back in the patient's mouth. Same thing like hearing aids or any devices, medications, we just don't transport those because if they get lost, it's an expense and people want, somebody to pay for them. Okay, again, infants and children. So probably below the age of, I don't know, 4, maybe 3, 4. Kids primarily breathe through their nose, not through their mouth. Just again, because of breastfeeding, that when they're breastfeeding, their mouth is on the nipples, so they have to breathe through their nose. So they just tend to prefer to breathe through their nose till probably 3 years, 4 years, maybe some kids. And because of that, if their nose is full of mucus because they have a cold, they're going to have a lot of trouble breathing, but really they just need to have their nose cleaned. So most parents know to do that, but you will come across parents who have no idea, and they'll have this kid with a totally encrusted nose, and they call because the kid's having a lot of trouble breathing, and they just basically need to have their nose cleaned. Sometimes you could just take a washcloth with some lukewarm water and, kind of wipe it around their nose and try to clear out their nose. Sometimes we actually have to spray some water up their nose, and it depends on the ambulance what they have to be able to do it. But when we do pharmacology, I'll show you when we administer some of the drugs up their nose, is a device we use that you could put some saline in and spray it up their nose. Obviously, CVS has those devices also. Some ambulances have things, some don't, to be able to do it. But a lot of times, just like I said, cleaning out the mucus in their nose makes them feel much better. Okay. What else? When we're ventilating kids, okay, we don't want to hyperextend. We don't want to have their head flexed. We want to keep it in a neutral position. And again, because of the short airway and the lack of a lot of need for air in their lungs, it's very easy when you're ventilating them to get air in their stomach. So gastric means stomach, distension means that it's swollen. So that if you overventilate somebody, you're going to see their stomach start to rise. And the problem again is that they could vomit and aspirate and stuff like that. So just remember, the pressure that you have to deliver to a kid is a lot less than the pressure you're going to have to deliver to an adult. So you just have to gear it towards just when you see the chest start to rise. Okay, we're never going to fully inflate their, chest because we don't breathe going, with crazy breaths each time and stuff like that. Okay, so we're basically at our respiratory conditions. So let me just see how many. Okay, let's do COPD, and we'll call it a night with this. Okay, so COPD again stands for chronic obstructive pulmonary disease, right? So everybody just calls it COPD because they forget all the words. So chronic means you have it all the time. It takes people probably about 20 years to develop it, okay? And once they have it forever. There are some procedures they're experimenting with to help people, but they're never going to cure the disease. Obstructive means that there's a narrowing or a decrease in the amount of air that could get into a patient. There's an obstruction. Pulmonary means lungs and disease, right? So it's basically 2 conditions that we deal with in, say, Rockland County. Emphysema, okay, and chronic bronchitis. Now, you and I and everybody's probably had bronchitis in our lives. It is not chronic bronchitis. Bronchitis that we get, sometimes is a infection in our lungs. Chronic bronchitis is a chronic condition, a condition you have for your entire life, where the cells that produce mucus overproduce it. Okay, they're damaged, again, typically because of cigarette smoking, but they're damaged and they overproduce it. Now, most people who have COPD actually have both. They have emphysema and chronic bronchitis. They don't just have one or the other. But emphysema is the more common COPD disease. Now, black lung disease is what they call coal miner's disease, which was years ago. We don't see this anymore. And it could be any industry. When people went into very toxic, dusty environments, chemical environments, gases, it damaged their lungs. Obviously, God didn't make us to breathe this stuff in, and it damaged their lungs. But again, nowadays, everybody works with respirators on and stuff like that. So we don't really see that as much. But it could happen, right? I mean, if you get somebody, for whatever reason, just doesn't wear a respirator. I mean, listen, we got people still treating patients on the ambulance are not wearing proper protection, and they're wondering why they're getting COVID. So it is possible, but we don't really see it anymore. So really for COPD, it would be emphysema and chronic bronchitis as far as the test goes. So the vast majority of COPD is caused by 90% is caused by cigarette smoking. Again, the incidence of COPD is a little less than it was because of there's less cigarette smoking, but you know, it's definitely down. The big question is, you know, how vaping is going to correlate to COPD. So there is definitely some, you know, issues as far as vaping goes, as far as the lungs and stuff like that. But it's too, you know, too new of a thing to really know how it's going to affect the lungs long term. Okay. So again, in chronic bronchitis, what's that? Okay. So in chronic bronchitis, again, the irritants, whether it be the cigarette smoke or the chemicals, whatever it is, the irritants, okay, damage the cells that are on the walls of the bronchioles that produce the mucus, okay? And when they do that, there's too much mucus being produced, okay? And the mucus basically clogs up the airways. So they have a hard time getting air in just because there's more mucus than there should be on the inside of the airway. And it's causing what they call mucus plugging that I'll show you in a minute, okay? So this is showing you the two conditions, right? This is a normal alveoli. So it looks like one big sac, except that inside that one big sac, there's multiple rooms, and these walls are where the gas exchange takes place. So the more walls there are, the more gas exchange takes place. In chronic bronchitis, because of the excess mucus, it's clogging up the entrances, not only to the alveoli, but actually to all the bronchioles, and doesn't let air get down there. In emphysema, it changes the structure of the walls so that instead of there being multiple rooms like there are over here, there's one big one, okay? So there's actually less area for gas exchange because you're losing these inner walls where gas exchange takes place. The other thing that happens is that the alveoli doesn't stay open like this. It actually becomes almost like a flat bag, so that every time the patient breathes, they have to inflate the alveoli to be able to have gas exchange. Okay,
Frank,
so
you once said that when someone has a problem with breathing, the brain starts calculating instead of calculating the
carbon dioxide,
CO2, right?
Right.
It starts going with the oxygen.
So
Is this?
good.
No, I'm asking. Is this the issue
Yes.
that changes it?
Yep. So in both of these conditions, instead of looking at the level of carbon dioxide, it looks at the level of oxygen. The reason why is that in these people, remember, I told you this takes years and years to develop, right? You know, 20, 30 years to develop. So this is a slow progressive process. So the day they develop it doesn't mean that they're having that change. But what starts to happen as they get more and more problems, their level of carbon dioxide is always high because they can't have good gas exchange. The body starts to recognize that and says, I can't 100% depend on that anymore. So I'm going to start looking at the level of oxygen. And if the level of oxygen is low, I'll tell the person to breathe more. And if the level of oxygen is high, I'll tell them breathe less.
So now, why give a CPAP if
Well,
it's going
here's
to
the
give
issue.
you more oxygen?
Okay, so
It's
you're
gonna
right.
shut
So
off.
here's the issue. Okay, so first of all, that phenomenon where the body starts to look at the level of oxygen versus the level of carbon dioxide is called hypoxic drive. So hypoxic means low level of oxygen, which is, again, in these people, that's the drive to breathe. Drive means what makes them want to do something, right? So hypoxic drive means instead of looking at carbon dioxide as the drive to breathe, it looks at the low level of oxygen. Okay, so now there is a theoretical concern, okay, that you put somebody who's, say, 70 years old who has COPD and they have this hypoxic drive. You put them on 100% oxygen, the body's going to say what? Well, the level of oxygen is perfect, so I do not need to ventilate them, okay? I do not need to breathe for them, so they don't need to breathe, and it could start slowing down their breathing. All of these patients who have this disease know they have this disease, are being managed by a pulmonologist, and are told the amount of oxygen to use. So when we go to them, we maintain them on the level of oxygen, okay, that they need unless they are dead or soon to be dead. Okay, so if they're dead or soon to be dead where we're going to ventilate them, then we ventilate them just like we would any other patient. But if they're conscious and they're having trouble breathing, our goal is to actually help their trouble breathing by maybe giving them albuterol. Okay. CPAP again would be a last ditch effort. So giving them medications that may increase the level of dilation in their airways is kind of the way we go with them. So typically it's more of a albuterol type of treatment. These are tough patients. The nice thing is that, again, there's less incidence of them because there's less incidence of cigarette smoking. So now this is mucus plugging. Okay. So basically a nice clear alveoli and an alveoli who has too much mucus in it because they have bronchitis, right? So this is an exaggerated mucus plug that was carved out of, dissected out of somebody's bronchioles of somebody who died, right? So again, here's another dead person's bronchial. They cut it open and you see the mucus in here where it actually acts as what? An obstruction. It's not an obstruction we can get out to, clear their airway. So mucus plugging is a real phenomenon. The only thing we could do to prevent it is to put them on humidified oxygen. Now, if we get there, right, and it happened, the humidified oxygen is not going to clear it. They're going to die. But we shouldn't put somebody on, non-humidified oxygen just because we're lazy. And that's unfortunately what happens, in the county. I mean, you'll be out on the ambulances, you'll see, you could ask the, average person, where's the humidifier? How do you use it? And they're going to look at you, like, I don't know, nobody ever does it. And that's, that happened. The other day, I was trying to take somebody down to Valley. I asked the ambulance for a humidifier and they looked at me like I was crazy. And I said, you guys don't have a humidifier? They're like, no. So I just documented, attempted to administer humidified oxygen, ambulance did not have one. So, sometimes you just can't do it. So it really depends on the situation. Okay. So again, we want to use humidified oxygen pretty much on every patient that has a respiratory problem, especially kids that we're giving oxygen to, but it's absolute that we have to do it on COPDers, which again are only going to be elderly patients, and asthma patients could be any age, right? Typically they don't give the diagnosis of asthma until over 1 year of age, but it could be any age patient can be having an asthma problem. Okay, so it's very important to have humidified oxygen on all those patients. Okay, now what's the difference between the two diseases? Again, in emphysema, we said the problem is that the walls of the alveoli start to break down, right? So instead of it being a normal alveoli with multiple compartments or rooms inside of it, it becomes one big bag. And here it's showing the bag inflated, but the bag actually collapses. So it's kind of hard to get air in, right? So that's what kind of happens there. Okay, so when they say the lungs lose their elasticity, it's not the lungs, the alveoli. So elasticity, like when you have elastic in your pants, it stretches. So here it doesn't do that. So that what happens basically is that the alveoli collapse down onto themselves, right? So now what happens is it becomes hard to ventilate, hard to remove carbon dioxide, hard to move oxygen in, right? And it just becomes I'm telling you, every breath is a problem. These people don't even sleep, more than a couple of minutes at a time because as soon as they fall asleep, they feel like they're not breathing right. So they have to sit up. It's a horrible, horrible life. They're very thin. They don't even take time to eat because, taking time to eat takes time away from breathing. So that's why they tend to be thin. They burn a lot of calories because they're using all their muscles to breathe. So if you want to be thin, that's a good way to become thin, but it's not a good quality of life. I mean, if you ever see these people, they're, these are the people in shul, on an oxygen tank. And it's the rest of their lives. That's the way they are. So, you're all pretty young. If you're still smoking or vaping or doing whatever you're doing, usually by the end of class, people are smart enough to, to stop. Okay. So what do we do for them? So obviously they're going to be in the position they're most comfortable in. So you maintain them. You're going to put them on some humidified oxygen at the level that they were on in the house. Okay. CPAP is a last ditch effort and transport to the hospital. We just don't want to make them any worse. Really here, we're not going to probably make them better. Okay. The only thing that I didn't put in here, which was added to the protocol recently, was you can consider albuterol on these patients. If they tell you that they've used albuterol and it helps them, and we'll talk about when we do pharmacology and also, tomorrow night when we do asthma, we'll talk a little bit about albuterol. But albuterol is what they call a bronchodilator, which means it opens up the people's airway, so it helps get more air down into there. Okay.
EpiPen wouldn't do the same thing.
I'm sorry?
EpiPen.
EpiPen would, but what does Epi do to the heart rate?
Okay, it brings it up because it constricts
So these are people that typically have very diseased lungs. So you really can't do it. I just wanted to show you just 2 more examples of mucus plugs. I mean, these were mucus plugs taken out of live patients. This is a dead patient. These were mucus plugs. They're actually, they have a procedure called a bronchoscopy, where they could bring a tube and a camera down into patients and pull things out of the lungs. So, you know, these things were, you know, quite, I mean, look, 6 inches long down. And so that entire bronchial, and you could see how it was in the main bronchial, but also into the subbronchials coming off of it, you know, that was completely obstructed. So those, you know, that's the situation. Now, again, it doesn't happen overnight. You know, these are people who have serious problems. In this situation, it's something called cystic fibrosis, which is a genetic problem where they actually produce too much mucus also, but from a different reason. It wasn't because they had COPD. But you know, these are serious life-threatening problems. Putting them on, you know, dry oxygen only makes it worse. So, you know, wherever you go, wherever you join, wherever you do, you know, I hope you don't learn the bad habit. But again, if you're taking somebody to the hospital on oxygen, I would put them on humidified oxygen. If your transport time is 5 minutes, I wouldn't put them on humidified oxygen. If your transport time is, you know, 10, 15, 20 minutes, they would definitely benefit from humidified oxygen if they're having a respiratory problem. Okay, so any questions on anything we went over tonight? And we'll pick up, just so in case I forget. We'll pick
CPAP.
up
On CPAP, do I put on also, I can put it through the humidifier, or it's too powerful?
So CPAP doesn't really work too well. So let me just 1 second. So we got a 111 out of 172. So yeah, we're a little more than halfway through. So that's a good question. I don't know. I've never tried that. That's a great question. I'd have to actually call up the manufacturer and ask them if there would be any reason not to. Oh yeah, there would be a reason. So I'll tell you what the reason is that for CPAP to work, you have to have a certain amount of oxygen running into the CPAP device, a certain amount of pressure of oxygen running in. So if you're running it first through the humidifier, it's going to take away a lot of that pressure. So it probably would not work.
You're right.
But again,
it
CPAP,
doesn't-
that's actually a really good question. You know what I'm going
it
to do?
dries, the CPAP will dry up much more.
You're
These
right.
patients have a problem. And,
Yep.
and
No, you're absolutely right. So I'm going to, what I'll do is, I can't promise you I'll remember. So if anybody remember to text me tomorrow, but I'll call up the head of respiratory therapy tomorrow at the hospital and ask them how they deal with that. You know, how they deal with that in patients. Now, again, you have to remember in the hospital setting, they probably have an IV flowing into the patient, and the patient's probably well hydrated, so that once the lungs sense they're starting to dry out, you know, again, we move fluid all around in our body all the time. So once they, you know, once they sense that the, you know, the lungs are starting to dry out, they probably have the ability to take fluid from, you know, inside the blood vessels and, you know, transfer it into the lungs to try to keep the lungs moist. But I will ask tomorrow. For us using CPAP, I wouldn't really worry about it because it's, again, going to be at the most in Rockland County. If you're, you know, I don't know, in Chestnut Ridge or you're in Haverstraw, you know, talking, I don't know, I guess Haverstraw would be the furthest, Stony Point, you know, Tompkins Cove up the Hudson River there. Those are the furthest points. Talking maybe 20, 30 minutes, the max. Other than that, you know, Muncie, you know, what are you talking, 10 minutes, the max? The way some people drive, you know, 7 minutes, 6 minutes. So I wouldn't really worry about it that much. That's why a lot of times, again, if I'm working in Ramapo, I don't even pull out some of this stuff because our transport time is so short. It's not even worth, you know, wasting the time to put it on them. So, okay. Does anybody have any questions? Okay. So we will pick up again tomorrow night, 8 o'clock. I'm going to have a optional class, Motzei Shabbos. I guess we'll do it again. Or we'll discuss it tomorrow night. We'll have a vote, but I think the last time we did it at 7:30. And what I'll do is we'll devote it mainly to going over trauma, in case there's any questions from the trauma section that you don't understand. I'm still working on the quiz. I know I keep on saying that, but I did a couple questions today. And then obviously, if you have any questions, Motzei Shabbos, on either the respiratory or cardiac emergencies, we can go over that also.
Frank, one question. When is COVID going to be over so we can go in the ambulance with you?
When is COVID going to be over?
So we can go in the ambulance with you.
Well, I'll tell you what my prediction is. So first of all, they proved my first prediction was I said that COVID was here in probably late November, early December. And today they finally came out and agreed with that. They said they looked at people who had donated blood in late November, early December, and they actually went back and tested. They always keep blood samples when you donate blood. They always keep a tiny little bit of your blood on as a sample, and they found COVID actually in blood back in December, early December, late November. So it was here much earlier than people were really saying. And the other thing, my prediction is that, well, we just had Thanksgiving. So we're only going to see that spike in about a week or two. So that's going to be, say anywhere from the end of this week till next week. Then we're going to go into Hanukkah, Christmas, and New Year's. So I would say that this second wave is going to start ending probably February, March. And by then also they'll start having the vaccine come out. I don't know how many people are going to take the vaccine, not take the vaccine, but they're going to start having the vaccine. The general public probably will only get the vaccine summer to fall, but first responders will get it probably spring, early summer. So I don't know. I think it's going to be around for all of 2021 pretty much. And then you'll start seeing less and less of it.
Doesn't it depend who wins?
No, it doesn't depend who wins.
There's a
So,
study that people are immune even if they had it just once.
well, no, so that's actually been proven too. So there's now cases in America. So we're cases in other countries, but there's now cases in America where people had it and got a second time. So the problem is that viruses have the ability to mutate or change. That's why, like flu, you have to take a flu vaccine every year. So COVID, the original COVID vaccine, the COVID virus from China, from Wuhan, really is not the prevalent strain of the virus anymore. So, it's already kind of changed. So there are people who got it early that could get the different strain now. They usually won't get it as bad because they had a similar exposure. But, just because you have it doesn't mean that you can't get it. And the other problem too is that the antibodies tend to drop pretty quickly. So, you may have been tested, in March and had crazy high numbers, but, by now your numbers are probably, very, very low. So there's no.
Don't tell me the side effects are the same. You don't lose the taste, right? The smell and taste are going to stay.
What about it? I'm sorry.
I don't want to lose my taste and smell again. So that the side effects changed, right?
I don't know. So I don't know. I mean, there's people still to this day. I know somebody still to this day who had it, still says that nothing tastes the same and smells the same. So I don't know.
Yeah,
I don't know. Some people got it.
People so well.
Based on what we spoke, there's no chance we're going to meet you in person.
I don't know. We'll see what happens.
Maybe I can meet you in Starbucks because they're giving free coffees to paramedics.
They're giving free coffee to paramedics
Every day this month if you're front.